Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. I'm so pleased today to kick off the release of the April 2024 issue devoted entirely to the topic of perinatal mental health and well-being. The issue came out on Monday, April 1st. Perinatal mental health refers to mental health conditions experienced during pregnancy and the first year postpartum. An estimated 15 to 20% of pregnant people experience a perinatal mental health disorder, and mental health conditions account for about a quarter of pregnancy-related deaths in the United States. The articles in this issue explore a broad range of mental health conditions, from perinatal mood and anxiety disorders to postpartum depression, post-traumatic stress disorder, serious mental illnesses, and more. As you'll hear in today's discussion, perinatal mental health needs in the United States are shaped significantly by structural factors. So a successful response to perinatal mental health needs includes not only clinical approaches related to screening, diagnosis, and treatment, but also broader social interventions looking at the well-being of the population as a whole. The issue we released on Monday builds on our successful October 2021 issue, which examined the same topic. But the current issue allows us to go deeper into the evidence and builds on what we know about successful interventions, broadens the lens to well-being, and highlights the experiences of some populations that have not been at the forefront of analysis and interventions thus far. As we get started, I just want to explain the way our event will run today. I'll kick off with an opening panel, which will feature the 4 authors of the overview piece in the issue, the introductory piece called Perinatal Mental Health, the Need for Broader Understanding and Policies That Meet the Challenges. After that, we'll have a series of panels, each of which will focus on a segment of the issue. The panels are a little bit arbitrary, but we want to get through all of the content, and so we've organized them into groups that we hope are functional. I do want to note we have a very tight agenda, and so we'll move through things quickly. We encourage you to spend more time looking at the content in the journal itself. If you're watching us live, you do have a Q&A button at the bottom of your screen. You can submit a question. Moderators will do our best to bring those into the conversation, but again, with limited time, I just want us to be realistic about our expectations. Now, the journal issue, as I noted, focuses on this topic, and of course, today's briefing does as well. We'll also have additional events, podcasts, and more, all of which you can find on the landing page at healthaffairs.org/maternal health, maternal and perinatal mental health. We'll spell that out and put it up on the screen for you. Sorry about that. Before we move into the content, some thanks are in order. Up on the screen, you can see our funders. None of this would be possible without the support of the Perigee Fund, the California Healthcare Foundation, the W.K. Kellogg Foundation, the Hilton Foundation, the Cambia Health Foundation, and the Con Alma Health Foundation. They support not only the issue and this event, but they've also made it possible for us to open up all of the papers free of charge to all readers, and that's a great service that they've provided. I want to thank our theme issue advisors, who I'll introduce in more detail in a moment, Tabb, Dina, and Emily Dossett. And I want to thank our editors at Health Affairs, Kathleen Haddad and Sarah Dine, both of whom shepherded this issue through to production. And now, without further ado, let's get into the content. We'll introduce our panelists and get started on the conversation. As they come to the stage, I will introduce Emily Dossett, one of our theme issue advisors, Associate Clinical Professor in the Department of Psychiatry and Behavioral Sciences and the Department of Obstetrics and Gynecology at the Keck School of Medicine at the University of Southern California. Tabb, Dina, the other one of our theme issue advisors, a professor at the University of Illinois School of Social Work. Co-authors on the lead paper also Twylla Dillion, Executive Director of Health Connect 1, and Alison Stuebe, a professor of obstetrics and gynecology in the School of Medicine and a scholar in infant and young child health development in the Department of Maternal and Child Health at the Guille School of Global Public Health at UNC. And I know I missed something there about your medical appointment, but it's all there in the materials. I should note that Dr. Stuebe also has another introductory paper in the issue that leads us to discussing the broader issues of well-being in addition to perinatal mental health. So the four of you make a great combination. Each of you brings your own perspective to the issue, and that's part of, I think, the strength of the opening paper in the journal. What I'd like to do to kick us off is two quick round robins through the four of you, and then we'll move more into a discussion. So because this was our second issue on the topic, the overview paper doesn't set the stage of the burden of poor perinatal mental health and well-being as much as it might have if this were our first issue on the subject. And so I'd ask that for our listeners who maybe aren't as steeped in the background on the topic, if you could set the stage for why it is important that we pay attention to this issue. And then I'm going to quickly turn to ask you, because of the four different perspectives you each bring, to spend a moment expanding on your work in the field and how the perspective that you bring shapes your thoughts about where we ought to go with this. So let's start with the first of just making sure that our audience understands some of the basic information regarding why it's worth an entire issue of Health Affairs and their 3 hours watching this and reading through the papers. What do we know about the burden of perinatal mental health? And I think, Emily, we'll start off with you if we can.
Sure, and thank you, Alan, so much. This has been a tremendous honor to be a part of this process. And writing this paper has been one of the most challenging and thought-provoking pieces. And I'm very grateful to Karen and Alison and then Twylla, Dillion, who is here as Executive Director of Health Connect One. I'm really grateful to all of you. So why do we think this is important and what is the burden of this? So I wanted to start as a psychiatrist by just saying a bit more about what it even is that we're talking about when we talk about perinatal mental health and substance use disorders. My whole career, when I tell people that I work with pregnant and postpartum people who are having mental health issues, everyone goes, "Oh, postpartum depression." And I go, "Yes, absolutely postpartum depression and all the other things," right? And so we started off our overview paper by actually talking about all the other things. So what do I mean? First of all, while depression is a huge part of what perinatal folks can be grappling with, there are a lot of other challenges as well. There is as much, if not more, anxiety among people who are pregnant and postpartum. There's a tremendous amount of trauma. Post-traumatic stress disorder is the official diagnosis, but even if folks don't kind of meet criteria, if you will, for that, there are all sorts of trauma-related disorders that people struggle with. There are more serious mental illnesses like schizophrenia, bipolar disorder that people really have more chronically and can get pregnant on top of that, and those symptoms can get worse in pregnancy and especially in the postpartum. And then substance use disorders, which often go hand in hand with mental health disorders and really have not gotten a lot of attention, even as this field has grown. So that's the whole range of perinatal mental health challenges. And also, I want to point out that what we're talking about is not just postpartum. It's not just in the first few weeks after someone delivers a baby, but it really is the entire pregnancy and even pre-pregnancy. And it includes the postpartum way beyond like the first 4 to 6 weeks where you're still kind of in touch with your OBGYN, but really all the way up to at least a year after delivery. And that's important because fully a third of people with perinatal mental health issues had them before they even became pregnant. A third developed them in pregnancy, and a third developed them afterwards. And some of the things we worry about the most, like suicide, are most likely to happen after 6 weeks post-delivery, when people really aren't even in touch with their OB anymore. So I just wanted to kind of set the stage about what the actual burden of sort of symptoms is that we're discussing before handing it off to one of my colleagues.
That's great. Thank you. Karen, as our other co-lead, maybe you could jump in a little bit here as well.
Yeah, I just want to say, despite how common these problems are, and how devastating they can be when they're untreated, the vast majority of individuals who are going to need help are not going to receive adequate care. And that's one of the things that we're really trying to hammer in our special issue, is the fact that those who need care are not getting adequate care. Less than half of people in this country will ever be asked the question, how are you doing? And so in this special issue, there are solutions in reach, and hopefully individuals who are watching today are going to hear some of those solutions, because there are many issues, but we know what to do and how to do things better in this country. I'll turn it back.
Okay. I think what I want to do is make sure we broaden the lens. You've both Emily and Karen, you've sort of talked a little bit about the perspective you bring to this. But I want to bring in Twylla and Alison to do the same, and then I'll return back, Emily and Karen, to you as well. So Twylla, help us understand how you're connected to this topic and how it affects your thinking about where we should go.
Thank you, Alan. So at Health Connect One, we train and support and advocate for community-based birth workers. So breastfeeding peer counselors, doulas is a big topic in this paper, and that's an area we work a lot, and then perinatal community health workers. Something that's unique about the folks that we work with is that they're reflective of the communities they serve. So having a fully interdisciplinary approach to supporting folks that are having perinatal mental health challenges means that we have folks that are boots on the ground, people who know their community, who speak the same language, who look like the folks that they support, because it's a shorter pathway to trust. And when we're talking about folks who are having some of these challenges, it's absolutely vital that the person in front of them, who they can see right in their own home or over the phone, or however that doula or breastfeeding peer counselor, whomever is working in the community, reaches out to them, looks like them, and understands, there's a lot less explaining that has to be done. And when those folks work in partnership with the healthcare system, I think we're really onto something in terms of being able to support folks.
Excellent, thank you. And Alison, bring us your perspective, please.
Yeah, so I love following this amazing team. And I think part of what I loved about working with this group is that this is not a single specialty siloed kind of problem to solve. It really does require reaching across disciplines and really across all of the people who care about humans, essentially. And I love this quote from Dorothy Roberts, who says, the thing about reproduction is that more than anything else, it tells you how a society values people. And I think it's really important to appreciate that mental health issues are the leading cause of death for birthing and postpartum people in this country. And that is an indication of how we as a society value people. Because if we can't keep people alive when they are bringing new life into the world, something is really not okay. And that really is a reflection about the dysfunctional systems that we try to operate in. And we elevated in the introductory paper that the elephant in the room is that we don't have a good comprehensive health system. And that is one of the reasons that we see this crisis. I also want to say that I think it's important that we not just keep people from killing themselves, but that we actually create the conditions for people to thrive. And that's something that we elevated in the primary paper, and that is also in the second paper that I led. I saw patients this morning and was chatting with somebody and asked, did she have mood issues with her first pregnancy, with her previous pregnancies? And she's like, well, yeah, with the second one, I felt really awful for about a year, but it wasn't that bad. And I kind of wish I'd done something. And I said, we don't want you to just be okay. We want you to thrive. And so I think that that's the North Star we need to aim for. And that absolutely means screening and treatment of people who are suffering, but it also means creating the conditions so that people who are entering parenthood are likely not to suffer. In fact, they're likely to be well. And so as the sort of medical subspecialist taking care of high-risk pregnancies, that may seem like a paradoxical stance for me to bring to this, but I think that if we're not aiming for thriving, then we're not winning. And it's important that we have that vision of what it would look like to create the conditions for folks to be well.
Okay, so we've heard a few words from each of you, but now let's dive in a little bit deeper. Emily, as you started, you explained your training and that it's more than postpartum depression. But expand on that thought and bring a little bit more of yourself into this, and let's talk about where we should go to try to address these issues.
Yeah, absolutely. So just to kind of bring in my own training and also build on what Alison was saying, You know, when I actually went into psychiatry, my intention was to go into child and adult psychiatry, or child and adolescent psychiatry. I wanted to work with kids and teenagers. And I got to that portion of my training and realized that quite a few kids who were there because of very early life trauma. And a lot of that very early life trauma was due to parents who had mental illness or had substance use issues that was not addressed, wasn't treated, wasn't recognized. And it just struck me like, why are we spending all this time kind of like repairing something that broke a long, long time ago when it seems a lot more efficient, quite frankly, and like healthy to kind of address that problem. And so I ended up switching into women's mental health. And this was a couple of decades ago now, and no one was really doing it. And I just felt like, this is crazy to me that all of these women are suffering and no one is paying a bit of attention. Like, I even was asked to give a talk by an OBGYN at a local hospital close to where I live. And the CME committee wouldn't even give CME credit for it because they said postpartum depression wasn't a serious enough topic to merit CME. Now everyone's cringing. Every one of my panels cringing. And it blew my mind. I was like, okay, here's a cause worth fighting for. So that is how I kind of got into it, and then came through clinical experience to kind of learn the range of what I talked about earlier. But at the end of the day, so much of this is about healthy mamas making healthy babies, and that the mental health of those first few years in a child's life, and we know this through years and years and years and years and years of psychology research too, sets the stage for that child's mental and emotional and even physical health for the entire rest of the lifespan. So if we want a healthy society with better health outcomes than we have in all dimensions, like, we need to pay attention to pregnant people in those first few years right after the baby's born. And if not, we're missing the boat. It just seems so obvious to me, which is one reason I'm so thrilled about this issue. So yeah, I mean, that's a little bit of how I came to this and why I think it's so important.
And Karen, you started by talking about people not getting the help they need, but you
Yes.
bring much more to this than that. So tell us a little more about yourself and how you entered this topic.
Yeah, so there's the lived experience or the lived expertise, and also the professional. For about 20 years, I've been in a research area for my crowd, which are perinatal social workers. We are the ones that round the hospital, check on you after you give birth, might help you through a situation with a neonatal intensive care unit stay or through adoption. We are going to be the ones responsible for following up on a depression screen. If you were administered a depression screen after giving birth, we're going to assist with the scores, the providing information, referral, and possibly follow-up for mental health needs. Very early on in my career, I noticed that individuals were responding to a suicide question. So many of the tools that we use to check on individuals to see if they have depression or anxiety have a question around self-harm or suicidal ideation. It's a very common question that says, you know, in the past 7 days, I've had thoughts of harming myself or others. This single question produces a cascade of reactions that take place in the clinic and outside of clinics to get people the care that they need. What was alarming to me is that people were responding to this question positively, affirming thoughts of death or thoughts of harming others shortly after giving birth, while still inpatient. So we have an individual who's about to go home with a tiny, tiny, needy little human that needs round-the-clock care. And they themselves are in need of round-the-clock care. So early on in my career, I saw this as an issue and wanted to climb to the mountaintop and shout, hey, what are we doing? And I've been in this space. So I've been researching maternal death, maternal suicide, death, both in the US and then globally. I'm working with the Global Burden of Disease study when we published results in 2013 saying, hey, our maternal mortality ratio has gone from 7 to 17. And then again in 2016, saying, hello, our maternal mortality ratio has gone up to 26. which may seem like a small number when you think 26 out of 100,000 people that have given birth, but that's actually a really large number. And if you start looking at states like mine in Illinois that are looking at about 120 people that lose their life after giving birth, that's at least one person for every county. That's one person for each community. These are real people that live and work in our communities. And if you look behind those deaths, I know I'm rambling here, but this is so important. If you look behind those deaths, the overwhelming majority of them are preventable. And they route right back to that depression screen that I saw 2 decades ago, where somebody says, something's not right. I'm having thoughts of harming myself, and you're sending me home with a baby. So this has become my life's work as a perinatal social worker to do research in this area to make sure we're increasing awareness, both with mom, but in recent years, I've been pulled into the baby space, working with those first 1,000 days that we know are so important for the brain development, cognition, growth, and one's ability to achieve a very full life. It all routes back to that first 1,000 days. So how do we promote maternal mental health? Get those resources and supports that we as social workers find, those resources and supports for physical health and well-being, as well as mental health supports set up. And lastly, it's personal. So those of you who know me know that I oftentimes work on the area of research engagement, making sure that we elevate voices of people with lived expertise. And this work has become very personal to me in recent years, where I experienced a suicide attempt in my own family during the pregnancy. And the person didn't have a history. So that, 1 in 3 individuals that don't have signs or symptoms beforehand are going to experience an episode that may or may not be caught in time during pregnancy. So the work is very personal as well. I'll give it back to you, Alan.
Thank you for bringing both of those dimensions in. It's so important. Twylla, you gave us again, you're sort of where you sit in the ecosystem, but I'd love to hear a little more about your own journey there and how it shapes your thoughts about what we should do in this area.
So my journey started with my first birth, right? I had my first child at 18, didn't have a doula. They were popping up in Illinois through Health Connect One's work, and they'd been around forever, right? But I didn't have that kind of support. I had my grandmother, who was a midwife, and was also very scared because she knew all the things that could happen. She was with me day and night. She came up from Jamaica and lived with me. So that was my first exposure to this work. Little did I know I'd end up here now. I come from a long lineage of midwives. I didn't know that either until I started digging. But this is the work I've been brought to earth to do, right? To help folks have access to people right in their own backyard, people who look like them, who they may disclose things to that they may not even disclose to their family. I think that what Karen lifted, and thank you, Karen, for sharing that. It brings a lot more gravitas to what we're talking about today. When you have someone in your family who's going through something like that, you may not know, right? We hear these stories all the time about people who are smiling and seem so happy, and then all of a sudden they're gone, right? That's not okay. People need access to a number of different folks they can connect with. So my work at Health Connect One is directly connected to my own experience, not necessarily having someone who I could tell everything to, and recognizing that a lot of these doulas and other perinatal community health workers that we work with, they have a different mechanism of getting information out of folks, right? It's so personal. It's socio-emotional support. It's comfort measures. You're right there with people and you're able to be in their space and they're welcoming you into their space. I think a lot of other models that I've studied, so I have a research background as well. That's just not my main gig. A lot of other methods that I've studied, home visitation models and several other ways that we've supported folks. Sometimes people don't feel as comfortable, right? Having someone come into their home, especially in the Black and Brown communities and Indigenous communities, because there's a fear, right? There's a fear that you're being looked at, even when folks are filling out the screener, right? There's a fear that if I respond to this honestly, someone could come and take my children. And there's nothing more terrifying. Think of the histories that our communities have faced, having their children taken from them. So there's nothing worse that can happen for people. So they're not going to necessarily disclose, but in the meanwhile, they're not getting what they need to be able to support, to be able to have that attachment early on, which is bidirectionally important. We know that. So they don't share. So that's why I sit where I sit. That's why I do what I do. And I keep pushing for community-based, culturally concordant doulas to get what they need. And this is something that's happening nationally. You see state by state, folks are taking on Medicaid doula reimbursement at a variety of rates, y'all. And that's not something that's sustainable. We need to make sure people are being paid appropriately. A lot of these doulas are also moms, right? And dads. Now we have some men entering the field. So they need to be able to earn enough money to be able to stay in the profession. They need to have support for their mental health because they're experiencing a lot of vicarious trauma as they work with these families. But thank you for asking out. I love what I do. I'm not going to stop doing it. It's very important. I serve on the Maternal Mortality Review Board, absolutely, a lot in New York State. A lot of these deaths are preventable, and we're recognizing that more and uplifting it a lot more. So I definitely, I'm just glad to be with this group, and I know there's plenty more to share. Thank you.
Thank you. And as you were speaking, I was reminded of a paper from our October 2021 issue about screening. There's so much emphasis on screening, and this was a qualitative paper describing lots of very rational reasons that people don't feel that they can that they want to answer accurately because of the history you described and the present and the lack of follow through if something is identified, as Karen mentioned earlier. So screening is not the panacea, as much as an important role it can play. Which brings me, I guess, nicely, Alison, you have, and we had a side conversation before today, you navigate this world of this very highly specialized medical practice, but also speaking very broadly globally about, well-being and thriving, and some of the things you said in the answer to my first question. So if you could just go a little, I'd love to hear a little bit about the evolution from sort of, deep clinical practice to these broader social framing of the issue.
Yeah, I think that I have had a long-standing interest in justice, I think is probably the best summary piece for it. And I can remember reading Jonathan Kozol's books when I was in college about savage inequalities. Was a really compelling, he's written a number of excellent books, but talking about, in that particular case, the environmental conditions in East St. Louis, across the river from St. Louis. I went to WashU for medical school, and it struck me that WashU has a lot of fantastic resources, and yet here's this community that does not. And I did an elective rotation my 4th year of med school with peds and OB in the clinic in East St. Louis, because I had been bothered by this since I read the book years before, to sort of think about what needs to happen here to make things more fair and more just. And so that's been a thread for a long time. I ended up in maternal fetal medicine because I love the complexity and challenges of navigating really difficult health problems in people who are also growing a child and bringing life into the world and balancing all those moving parts. And I recognize that their social context is at least as impactful as anything I can hope to offer them. So I think that I got particularly interested in the postpartum period after my 3rd child was born, and I had a pretty significant postpartum hemorrhage and a transfusion reaction, and so couldn't really get transfused properly. And when I went home, my midwife said, "You need to stay in bed. Like, can't do anything. You stay in bed, you feed your baby, you don't do anything else." And I had, my older kids were 7 and 4, and I would have gone to swimming lessons and like dragged around with them to be a good mom who was present. But I was like, I have to stay in bed. That's what the midwife said. It was amazing. And I thought, what is wrong with the world that I had to bleed down to a hemoglobin of 6 to do the reasonable thing, which is to go home and snuggle up with my baby. And so I think that really planted a seed of thinking about how we don't support people in the postpartum period at large. I've been saying for a long time now that if the baby is the candy and the mom is the wrapper, once the candy's out of the wrapper, we tend to toss it. And that's not okay. And so with a bunch of colleagues at UNC, Kristen Tully, who's a co-author on this paper, was instrumental in our developing a PCORI grant around the 4th trimester. Sarah Verbeest, who's a co-author on another paper in this issue, was the lead on that project. And we started to think about what needs to be in place for people to be well after giving birth. So in many ways, the paper that's in this issue, which talks about vital conditions, takes the framework that the Ripple Foundation developed to think about what makes humans thrive, and then apply it directly to perinatal mental health. And I think one of the really profound pieces of this that aligns with what everybody is saying is that the center of vital conditions is belonging and civic muscle. So when Twylla talks about having someone who looks like you, who you can confide in, who you can connect with, that's what we need as humans. We are hardwired for connection. When we don't have it, it makes us sick, physically and emotionally. So we need to cultivate that community. There are interventions like group prenatal care that can do that. Sabia Wade, another of our co-authors, runs fantastic doula programs and has demonstrated the role of doulas supporting what Twylla has described. And then Fran and Meredith, who are co-authors, have done amazing work in Cincinnati with a program called Queen's Village. And I think this really illustrates the power of belonging and civic muscle. So Queen's Village was founded to address the stated need of folks living in neighborhoods affected by infant mortality to have a place they could go to be with other Black moms. So the URL is blackwomenforthewin.com, which is brilliant. And the program was developed just to be a space. They have yoga classes, they have enjoyable activities, they have pain and sip, but not with alcohol because they're pregnant, but just fun stuff to come together. And out of that, participants started talking amongst themselves and said, you know, we don't like the care we're getting at some of these hospitals. There's some bias going on and there's some mistreatment and some disrespect. And so the members of Queen's Village said, we want accountability. And they have created a program called Mama Certified, where all 5 maternity hospitals in Cincinnati report their process and outcome measures by race ethnicity. So they created that civic muscle to demand that accountability. And so I think that we certainly need to treat acute disease, like got to do that. And we need to think about how can we facilitate folks coming together and saying, this is what we want, we demand accountability, and we're going to get it. Because I don't think the systems are going to change just because we read a paper about it, right? They're going to change because the people who are affected show up and call their state senator and their congressperson and their senator and the president of the United States and say, this is unacceptable. And so that's where we need to go.
Well, we're getting some nice questions in from the audience. I have one more question and it might turn into 2 for the panel before, and then depending on time, we'll see what we can do with those. But as we've discussed, you all come at this from different perspectives, and you came together and wrote a paper with some recommendations for change. And I'm curious where it was easy to find alignment and where maybe you struggled. Maybe you struggled, someone preferred one over another. Maybe there was a prioritization difference. I can tell you have some general alignment in your thinking, or you wouldn't have been able to submit the paper. But would love to hear a little bit about what brings you all together and what maybe also keeps you with a creative tension amongst each other. Who's prepared to talk about the inside working, the making of the sausage, as they say?
I'll take this because I'm going to take it early to do the easy part, which is the part where we actually were aligned, because we were actually pretty aligned, I'm going to say, through the process. You know, I think one thing that we all brought to this, you know, OB, psychiatry, social work, advocate, researcher, like are coming at this, but what we all realize in our day-to-day work is that you can't work in a silo. You can't work by yourself. It just flat out doesn't work. And you can't look at the perinatal period or pregnancy in a silo, right? Like everything that comes before and everything that's going to happen after plays into it. I can't prescribe medication just to prescribe medication in a silo. It's not going to work. I mean, if I have someone in front of me who is unhoused, or someone who has literally no social support, or someone who is in an abusive relationship, those are extremes, right? But they happen all the time. Like, what's my antidepressant going to do for them? Not much, right? Not much at all. So all these other factors have to tie in. So, you know, hearing about Twylla's work with community-based organizations and doulas is like one piece of that puzzle, right? And Alison's emphasis on justice and reproductive justice and the framing of the big picture is another piece of that, right? And everything that Karen's done with, you know, the disparities in research and how so many groups of people from minoritized populations are not included in research and should be, was another piece of the puzzle. So I would say we were pretty aligned. I think the 7 policies that come out of our paper really bring that to light. And I think we all also believe that this is possible, though to varying degrees. I'm a little more of a naysayer than Karen, who called me out on that once or twice. But we are, we see policies that are out there that are doable, that are evidence-based. It's just putting the political muscle and will behind it.
Other perspective, Karen?
Yeah, I'm
That was my answer.
looking at Emily. I'm going back because I mean we do have some heat between us, some tension that's very healthy in terms of how do we get to those solutions and how do we actually provide holistic care for those in need and what supports are actually possible. And the system is wrecked. Many of the pieces are there. Folks don't know that they need them, for one. So how many of us have talked to folks that were in an episode and never knew it, right? Or we might experience rage. Your provider's not talking about rage. So there are limited resources at play. We reference the access programs in our paper. One of them is the National Helpline for individuals to receive support and peer support throughout their pregnancy for mental health needs, operated through Postpartum Support International. But how many individuals know that that's the care that they need? And that was some of our friction in writing the paper. So I think in essence, throughout it, that we were in alignment saying we can all do better. And even doing a little better has so much more impact. We referenced the need for broadening our understanding and our definitions of who's included in these focal points, who's included in research studies, who's approached in clinical settings. So we know that Black, American Indian, Asian, multiracial people are less likely to be screened for depression. And without a screen for just depression, you're not going to be routed through care to actually make it to a diagnosis and or treatment and or remission. So there are these gaps and these missteps that we can work on collectively if all of us are doing just a little better. So someone else was going to say something.
Well, let me try to bring in a couple of the questions just in the few minutes that we have remaining there. A number of people have asked about parental leave, family leave. In the list of policy recommendations in your paper, you talk about supporting families, and family leave is part of it, and childcare is another part of it. So I wonder if any of you, I would encourage the audience, if you want to read all seven, if you want to get all seven recommendations, read the paper. But since there were two questions from the audience about this one in particular, I wondered if one of you would just want to say a little bit more about the evidence base for it and what we ought to do. Alison?
Yeah, so, and this is in both the papers that I'm involved with. It's a no-brainer. Every country on earth, essentially, every high-income country on earth has paid family leave. You cannot work and care for a newborn at the same time. You cannot do productive work and reproductive work simultaneously in the early days. And so we need to accommodate that reality. There are more and more states that have enacted family leave programs, which are awesome. Many of them, though, require you to have worked a certain number of hours before you can get them. Well, if you have a baby before you've had a full-time job, you still can't earn money while you have the baby. So we need to recognize that this is really a human rights issue. And I think that there's ample evidence that it reduces postpartum depression, it improves infant development, it reduces infant mortality. Like, this is an obvious thing that civilized countries should do if they believe in the perpetuation of humans. And so I think we really, really need to get this enacted and recognize that if we value families, we need to put our money where our mouth is. It's interesting that the happiness gap for American parents compared with non-parents is higher than any other OECD country. We also rank 37 of 40 on how much money we spend on family benefits. I do not think that is a coincidence. So we need to step up and, can we be at the 50th percentile for investment in families? That would be a big switch.
So I'm going to try to power through a few topics a little more quickly than I would like. One question came in early, and I'm going to modify it slightly. I just think it's such a great question. It says, so many in-home supports postpartum are refused by new moms. During the chaos of discharge from a hospital, the information is placed in a large packet How do we get hospitals to open their doors to organizations that see new moms and families as people instead of a pamphlet? And I want to broaden that, because I don't think it's just hospitals, and sort of ask more generally, how do we get the systems that largely control the flow of dollars and information to view organizations that, as this questioner said, see new moms and families as people, to take a broader view? Twylla, you want to start with that? I
Yes,
bet you
I'm
have
just
some
over here
experience with
nodding
that.
feverishly. Yes. Getting into communities, I think, is the big answer, right? We've been talking about it. So folks who are working in community already and know the community and can share that information again. I remember leaving the ED with my last child and going past the ER and worrying that I was going to get COVID. I don't remember anything that was in that folder they gave me, and it came home and went in a drawer. Thankfully, I knew where to go to get what I needed, but a lot of folks don't, right? It is such a harried point in time that having another checkpoint once folks are back home from a doula, from someone who works in the community or another community-based organization that does see folks as people and really wants to make sure people are thriving in community is essential. And that a way to do that is through interdisciplinary partnerships, right? And doing it in a way where those partnerships are respectful. That's another really important piece of this, right? So if a doula enters a home and recognizes that someone is maybe in a crisis, they're not a therapist, they're not a social worker, but they know someone's going through something really difficult or traumatic, they can then work with that person to reach out. So they're not going to be the one that does the outreach, but they can work with that person to reach out to the support that they need, right? Like, these are things that should already be happening in a lot of communities. This is actually what is happening, but we need to see it more broadly, especially because we do have, so combining issues, that shortened amount of time where you do have maternity leave, unfortunately, or parental leave in this country. You really want to double down and make sure people have all the supports they need, especially during that period and after.
Great. Okay, I'm going to close with this question. I think I probably know some of the answer, but I'm not sure the audience does. But the question is, the Federal Maternal Mental Health Task Force is producing its National Strategic Plan next month. If there were one or two things that you want to see from federal and state governments in that strategy, what would they be? And I'll do a round robin with each of you, and then we're going to have to, I'm sorry to all the other great questioners, because there are questions that came in, they were really excellent. But let's close with this and we'll keep our program moving along.
Mine's quick, and I don't serve on the task force. I'll say it's better integration with home visiting supports and coordinated intake. As mentioned, the community supports that are there need more muscle around maternal mental health. So this is one of these great points where we can leverage the synergy between these in-home community-based models.
I'm going to say funding, right? So funding for community-based doula and other community-based models that support birthing families, training, and then payment.
I'm going to go big. Universal basic income for parents.
Yep. And I would say expand the workforce, both expand the workforce in terms of who is in the workforce. We need to include doulas, community health workers, all the folks that provide that support. We also need to make sure that the people who are currently working with pregnant and postpartum people, whether they're OBs, social workers, psychologists, have the training to take care of perinatal mental health and substance use disorders. Right now, it is not mandated by any professional organization. And I think having a universal certification that's recognized for disciplines, it's going to make sure people are competent in dealing with this. So that's kind of two sub answers, but it all comes back to expanding the workforce.
Well, I'm glad you all answered, because you went in some respects beyond your paper and yet drew from the paper, and that's terrific. So what a great start. I appreciate the contribution of the paper that I really hope folks in the audience will read in addition to listening to this. Doctors Dossett and Tabb, Dina, thank you for being on the panel and guiding us through this entire issue. Doctors Dillion and Stuebe, thank you for joining with the panel as well. This was just an amazing conversation. And with that, I'm going to launch us into our next panel, which is on the burden of poor perinatal mental health. And we have the good fortune of having Twylla Dillion rejoin us as the moderator for this panel. So I'm going to step away for a moment, turn it over to Dr. Dillion, and let you run us through the next panel.
Hello again, everyone. I'm so excited to be facilitating this panel, and the panel includes Slawa Rokicki, Assistant Professor, Department of Health, Behavior, and Society and Policy, Rutgers School of Public Health; Sarah Haight, Doctoral Candidate, Department of Epidemiology, University of North Carolina at Chapel Hill; Bridget Blebu, Faculty Investigator, Lundquist Institute for Biomedical Innovation, Harbor UCLA Medical Center; Stephanie V. Hall, Postdoctoral Research Fellow, Department of Psychiatry, University of Michigan Medical School; and Kara Zivin, Marcia A. Valenstein, MD, Collegiate Professor of Psychiatry, University of Michigan Medical School. And I will turn it over to Slawa.
Great, thank you, Twylla. My name is Slawa Rokicki. I'm an assistant professor at the Rutgers School of Public Health, and I study maternal and child health inequities and ways to address them. So I'll be sharing my work titled Perinatal Depression Associated with Increased Pediatric Emergency Department Use and Charges in the First Year of Life. Next slide, please. Emergency department, or ED, visits in the first year of life are common, but these visits are often low resource, non-emergent visits that are preventable with primary care. Use of the ED for non-emergent reasons is not a good use of healthcare resources and is particularly costly to Medicaid, which pays for over 60% of all pediatric ED visits, a proportion that's been steadily growing over the past decade. Perinatal mental health is associated with a range of adverse child outcomes, including ED use. However, we don't know very much about whether this increased use is attributable to emergent or non-emergent reasons, which is particularly important for assessing policy implications. So in this paper, I explored this relationship between perinatal depression and infant ED use in more depth. To do this, I took advantage of a very unique policy environment in New Jersey, which is New Jersey's Universal Perinatal Depression Screening Program. New Jersey was the first state to implement universal screening in 2006. And then screening occurs at the time of delivery before discharge from the hospital. And the screening results from the Edinburgh Postnatal Depression Scale is recorded on the birth certificate. As a state, we are still very much working on translating that screening into access to treatment and improved mental health. However, from a research perspective, what's really innovative here is that we have screening data on perinatal depressive symptoms for nearly everyone that gives birth in hospital, about 95% of birthing people. And I'm able to link that birth record data to the infant's hospital discharge records for the first year. So this presents a really unique opportunity to use the screening data to examine the relationship between perinatal depression and infant ED use and charges at a population level. I categorize the depression score into level of symptom severity, that is none, mild, and moderate to severe. I use a validated algorithm to classify these ED visits as emergent or non-emergent. And finally, I examine differences in these associations by primary payer at delivery. Next slide, please. So first, I find that both mild and moderate to severe symptoms were associated with increased infant ED use and charges in the first year of life, with higher use as symptoms increased in severity. So infants with mothers with mild symptoms had 10% more ED visits, while infants with mothers with moderate to severe symptoms had 21% more visits compared to those with no symptoms. This is after controlling for a wide range of maternal, paternal, and delivery characteristics. Second, when I looked at the reasons for the ED use, I found that perinatal depressive symptoms were associated with greater non-emergent ED use, but not significantly associated with emergent ED use. So that means that these increased visits were likely for low acuity conditions that were probably preventable in primary care. Finally, I find quite striking results by payer in that among infants whose delivery was financed by Medicaid, total ED charges in the first year were 43% higher for infants with mothers with moderate to severe symptoms and 19% higher for those with mild symptoms compared to no symptoms. And this pattern was not seen among infants with commercial insurance. Next slide, please. So this research yields several policy implications. First, as Medicaid is the primary payer for a disproportionate share of pediatric ED visits, policies that can interrupt the relationship between perinatal depression and non-emergent ED use have potential for positive return on investment. So for example, expanding Medicaid coverage to home visitors, community health workers, or doulas could support maternal well-being while addressing or triaging infant care needs. And I think that very much echoes Twylla's comments in the first panel. Other policies like redesigning reimbursement to incentivize co-located mom and baby services, along with extension of coverage to 1 year postpartum, would also help to facilitate the assessment and treatment of perinatal depression. This study also demonstrates the benefits of universal screening, particularly screening at the time of delivery. While screening at multiple time points during pregnancy and the postpartum period is ideal, an advantage of screening at delivery is that it reaches nearly all birthing people before they leave the hospital. And that's important because we know that, especially among the Medicaid insured, nearly 40% of postpartum people do not attend their routine postpartum visit. So identifying people in hospital who may be at risk of postpartum depression is really important for reaching all perinatal people, particularly the most vulnerable. However, as Alan mentioned, screening is not a panacea, and for screening policies to translate into improved outcomes, screening must be followed with accessible and culturally appropriate care. I think one example is the perinatal psychiatry access programs that are a promising model for bridging the perinatal and mental health care systems, and I look forward to hearing more about that later in today's agenda. And finally, routine depression screening in the ED could also play an important role in identifying perinatal people with mental health conditions. Studies have found that postpartum depression screening in a pediatric ED setting is feasible, but I think we need more work to understand the best ways to implement this in patient-centered and non-stigmatizing ways. Next slide, please. Thank you. I want to acknowledge the funding that I received for this research from the New Jersey Integrated Population Health Data Project at the Rutgers Center for State Health Policy, and I look forward to your questions. Thanks.
We're going to turn it over to Sarah. Sarah Haight.
All, thank you for tuning in today. My name is Sarah Haight. I am a PhD candidate in epidemiology at UNC, and I'm going to give a brief overview of our paper on racial and ethnic inequities in postpartum depression care. So to start with a little background, we know that postpartum depression is common. Approximately 1 in 8 postpartum people suffer from postpartum depressive symptoms, and these symptoms can have devastating impacts on birthing people and their families. Effective management may include screening by a provider and, where applicable, provision of a diagnosis and treatment, as has been previously stated. However, existing research shows that people are not equitably supported along this continuum, which has also been alluded to in the panel. Specifically, a few studies have documented notable racial disparities in care at the screening and treatment stages. And while these studies are informative, we're often occurring in a single state within one type of payer like Medicaid, or we're only able to collect data from one point in time. So we really wanted to look at patterns of postpartum mental health care across the entire first year postpartum in multiple settings. So for this paper, in order to understand whether inequities exist in postpartum depressive symptoms, diagnosis, and care, we use novel survey data led by Dr. Jamie Daw at Columbia University. So on the slide here, you'll see where the data came from, the Postpartum Assessment of Health Survey, or PAWS. This survey is an extension of CDC's PRAM survey, and both of these were distributed to samples of birthing people using 2020 birth certificate data. PAWS participants come from Michigan, Pennsylvania, Utah, New York City, Kansas, New Jersey, and Virginia. And for the current analysis, we got postpartum depressive symptoms from this 2 to 6 month postpartum mark, and receipt of a perinatal mood and anxiety disorder, or PMAD diagnosis, and receipt of postpartum mental health care from this 12 to 15 postpartum mark. That's one of the really unique pieces of this analysis, is we were able to get information from the entire time since birth. And after waiting, PAWS data is representative of all people that delivered a live birth in 2020 in these 7 jurisdictions. Next slide, please. So to get into some of our results, among our sample of over 4,500 postpartum people, approximately 12%, or nearly 1 in 8, had postpartum depressive symptoms. Of note, the prevalence of these symptoms varied by various factors, and we saw that the prevalence was highest among those that were multiracial or Black, and that hovered around 16 to 18%. This was closely followed by individuals that were Asian, Native Hawaiian Pacific Islander, Southwest Asian, Middle Eastern, or North African. These individuals showed a prevalence of nearly 14% that had postpartum depressive symptoms. And while these confidence intervals overlap, the patterns are indicative that these 3 groups potentially have a higher burden of symptoms during this time. Next slide, please. And so among those with postpartum depressive symptoms, we investigated whether or not there were differences in PMAD diagnosis. Of note, there were huge gaps in care. only about a quarter of those individuals with symptoms received a diagnosis during pregnancy or postpartum. Across race and ethnicity, we didn't see significant differences in PMAD diagnosis, but patterns do indicate a lower prevalence of diagnosis among those that were Asian, Native Hawaiian, Pacific Islander, and Black. Next slide, please. Moving to the right side, we see stark inequities in receipt of postpartum mental health care. Asian, Native Hawaiian, Pacific Islander, Hispanic, and Black postpartum people were significantly less likely than white respondents to report receiving any form of care in the entire postpartum period. So as a reminder, and as the title says here, all of the individuals in these charts had some form of postpartum depressive symptoms in the early postpartum period, all of them. And of these folks, only 20 to 37% of Asian, Latina, and Black postpartum people reported receiving any form of care, a vastly different number than the 67% of white postpartum people that received care. And in care, we're including counseling, medications, group therapy. Next slide, please. So what do we do with these results? You can take a look at the paper for a more substantial discussion on the findings, but I wanted to highlight recommendations in the form of 3 buckets. So our first are clinical implications. I look to existing qualitative work, which has demonstrated that racially minoritized postpartum people experience additional barriers to perinatal mental health care related to previous history of medical trauma, healthcare-based discrimination, provider bias, and culturally based stigma surrounding mental health. And so I highlight their recommendations to increase the diversity of providers, increase the culturally responsive and language-specific screening and treatment options, and mandate provider training on universal screening, referral, and treatment across all types of insurance. Additional strategies that may stop individuals from kind of falling through these cracks along the continuum from screening to diagnosis to care may include warm handoffs and collaborative care models, just to name a few. Next slide, please. The next bucket is policy implications. So equitable access to continuous postpartum insurance coverage may help to reduce some of the observed disparities. In our paper, we support the Centers for Medicare and Medicaid Services recommendation to extend coverage for 12 months postpartum for Medicaid recipients, and also that states adopt all available Medicaid resources like extended coverage for recent and undocumented immigrants, and as well as including coverage for screening and care of depression at well-child visits, which research shows are more equitably attended than the postpartum checkup. And the implication of the implementation of any of these strategies at the start of the continuum, closer to screening, will likely help diffuse disparities down the line. Next slide, please. As it pertains to research moving forward, more data is needed among multiracial and American Indian and Alaskan Native postpartum people. The current study, we suffered from some small sample sizes in these groups, which just further mask the postpartum mental health needs of these folks. There also needs to be future work investigating how interpersonal and structural racism can explain these inequities and what efforts are needed to address these mechanisms and their harms. Next slide, please. And so I just wanted to acknowledge the PAUSE survey respondents, as well as Columbia University and all the state departments that made the PAUSE study possible. And then my funding from NICHD, all my co-authors and dissertation committee, which made this research project possible. Thank you, and I look forward to the discussion.
Thanks, Sarah. Now we'll transition to Kara Zivin.
Thank you for inviting me to speak with you today about the trends surrounding mental health conditions during pregnancy and postpartum. Next slide, please. As many of us know in this audience, the U.S. is unique among high-income countries and faces a growing maternal health crisis with negative impacts on birthing people and infants. Stark disparities in maternal morbidity and mortality, including mental health conditions, stem from social, structural, and policy features of U.S. society. Next slide, please. Maps are important and can help us tell a story about geography and our lives across places. In our study, we characterized trends in perinatal mood and anxiety disorder diagnoses and associated suicidality and psychotherapy use among privately insured birthing people. We used administrative medical claims representing privately insured people with inpatient deliveries resulting in a live birth across the United States. Our cohort included women aged 15 to 44 with continuous enrollment in a single health plan for 12 months, both before and after delivery. Although previous analyses of perinatal and mood and anxiety disorder diagnoses have focused on prevalence, our study examined trends in diagnoses at the national and state levels, making state-to-state comparisons. We also examined contemporaneous perinatal mood and anxiety disorder associated trends in suicidality and psychotherapy receipt by state. Additionally, we incorporated pre and post Affordable Care Act trends. Next slide, please. We found that nationwide, perinatal mood and anxiety disorder diagnoses among privately insured people increased by over 93% from 2008 to 2020, growing at a faster rate between 2015 and 2020 relative to 2008 to 2014. Most states and demographic subgroups experienced increases. Next slide, please. This figure provides more detail showing that perinatal people in all race and ethnicity, age, and geographic categories experienced growth in perinatal mood and anxiety disorder diagnoses from the pre to the post Affordable Care Act era. Among races and ethnicities, Black people saw the largest increase of 55%, of roughly 1,400 to 2,100 per 10,000 deliveries. The initial prevalence of perinatal mood and anxiety disorders was highest among the oldest people in our cohort, ages 40 to 44, yet the youngest people, aged 15 to 24, experienced the largest increase in diagnoses of nearly 50%, or roughly 1,900 to 2,800 per 10,000 deliveries. Next slide, please. Suicidality shown on the left and psychotherapy shown on the right among these individuals also increased nationwide over the study period. Relative to 2008 to 2014, psychotherapy rates continued to rise in 2015 to 2020, whereas suicidality rates declined. Taken together, these findings suggest a worsening of maternal mental health morbidity in the United States. We hope that the maps we produced begin a conversation about perinatal mental health needs across our country, with the goal of achieving equity in access to care. To better inform policies that address this crisis, and as public health and policy shift post-pandemic, future studies could assess post-2020 trends among commercially, publicly, and non-insured people. Next slide, please. To learn more about our study, please read the full article in Health Affairs. To learn more about our perinatal mental health services and policy program at the University of Michigan, please look at our website or use this QR code. I'd also like to acknowledge our funders, the National Institutes of Health. Thank you.
Thanks, Kara. Now we'll transition to Stephanie Hall.
Thank you so much for having me here today. My name is Stephanie Hall, and I'm a postdoctoral research fellow at the University of Michigan. So I'm very pleased to present our most recent paper, which describes trends in post-traumatic stress disorder, or PTSD, during pregnancy and postpartum. Next slide, please. So PTSD is a mental health disorder that occurs in response to trauma. And literature indicates that somewhere between 3 and 4% of people will experience PTSD during pregnancy or postpartum, a time known as the perinatal period. Perinatal PTSD is associated with numerous poor outcomes. And studies show that in the United States, people of color are more likely to experience trauma and therefore more likely to experience PTSD in the perinatal period. Now, a lot of our work has focused on perinatal depression and anxiety. And so we know considerably less about other maternal mental health disorders like PTSD. In fact, we currently have no estimates on the diagnosis rate of PTSD at the population level during pregnancy and postpartum. And diagnosis is a really important marker because it's frequently a prerequisite for treatment. And it can show us who our healthcare system is supporting, and by contrast, who we may be missing. So our team set out to study PTSD diagnosis rates in over 600,000 delivering people across the United States using commercial insurance claims. Next slide, please. And we found that between 2008 and 2020, PTSD diagnoses increased 394%. In the most recent year of the study, 190 in 10,000 deliveries had a PTSD diagnosis. That's just under 2% of the delivering population. So obviously, this is a huge increase, and it affects a very large number of people. But I want to draw your attention to a few caveats about these trends. The first is that this is an increase in diagnosis and does not necessarily reflect PTSD itself. So when we look at these trends, we should think about them as a function of what the healthcare system is doing. So second, remember that literature shows us 3 to 4% of delivering people experience PTSD. But we found that only 2% have a PTSD diagnosis, meaning that while these diagnoses are increasing, we're still likely missing a number of true cases. And finally, although diagnosis did increase among all races, you can see in this slide that white women were consistently more likely to have a diagnosis. But remember, people of color are more likely to experience PTSD. So this may indicate that our healthcare system is mostly underdiagnosing or missing PTSD in people of color. Next slide, please. Now, perinatal mood and anxiety disorders, or PMAD, are the most common pregnancy-related comorbidity and have also been rising in recent years and also exhibit racial disparities. And so when we look just at deliveries with PMAD in this blue line here, we can see a similar growth in PTSD, but of a larger magnitude. And this makes sense because disorders like depression and PTSD are highly comorbid, but it may reveal other nuances about maternal mental health care, like which patients we should screen for PTSD, and raises questions like, are PTSD symptoms initially diagnosed as PMAD? So ultimately, more work needs to be done to both understand these trends and then apply this information to better care strategies. Next slide, please. Because remember, diagnosis is a critical first step toward treatment and improved outcomes. So the thing that I want you to take away from this work is that while PTSD diagnoses are increasing, disparities persist, and we can do better. We need research and funding to develop and evaluate evidence-based PTSD screening guidelines that can tell clinicians when, who, and how to screen. And we need to ensure that those guidelines are properly incentivized in the context of prenatal bundled payment structures. And finally, racial disparities in mental health care are nothing new. We need to seriously invest in culturally sensitive and trauma-informed education and hiring and clinical protocols across the board to better serve all patients. And if we do these things, then we can better support patients with perinatal PTSD. Next slide, please. So to learn more about this study, please read our full article on Health Affairs or visit our program link, which is on the screen here. Thank you to my team who are all featured on our program website and to our funders at NIH. Thank you.
Thank you, Slawa, Sarah, Kara, and Stephanie. I wanted to just address a couple questions that showed up in the question and answer before we jump into other questions and give Sarah an opportunity to respond. So before we move on, we noticed there are a couple questions relative to Native American or American Indian populations not being included. And I wanted to point out that that's not an oversight. It's just a small sample size, and that's necessary to preserve confidentiality of the respondents. But Sarah, if you wanted to add any more, I'm going to give you the opportunity to do so before we move into other questions.
Yeah, I appreciate this getting brought up because originally we had those folks having a label in the figure, but then no data shown, and ended up just removing that for clarity of the figure, but hopefully it's more clear in the paper that we did collect data, or the study did collect data on American Indian, Alaskan Native postpartum people. Super important to be looking at all kinds of outcomes among these folks and what needs are. But after we restricted to our sample with postpartum depressive symptoms, it was too small to be able to publish those numbers. And we have to work with all the state departments that were willing to give us their data. And so those sample sizes were too small. And it's really unfortunate because it just further obscures the mental health care needs of these individuals. And so that's kind of why I made that call for, we need future research with more robust sample sizes to be able to document that. Yeah, thank you. And we didn't want to, sorry, we also didn't really want to do a other category and just kind of lumping people together. That was a discussion that we had, but I feel like that's typically a strategy when you're struggling with some small sample sizes, but we kind of wanted to avoid that as well.
Thank you, Sarah. So I'm going to jump into some of the questions. And then the first one, I'm curious about the Hispanic rates being so low for postpartum depressive symptoms, especially being lower than non-Hispanic white. This surprises me. Do you have any explanation why this might be? Are they self-reported? Or maybe Hispanics are less likely to admit they're experiencing distress? And you can, whoever wants to go.
I'll just start with, in ours, we did see the lowest rate of postpartum depressive symptoms among Latina postpartum people. And it is consistent with a few other studies I've seen that have used the PHQ self-reported symptoms. And so I'm not exactly sure what's going on there, but it is all self-report. And it also might be a factor of the states that we did have and the setting in those states and how folks are feeling willing to express their symptoms in the surveys.
Thank you, Sarah. All right, we'll go to the next question. Is there evidence that postpartum depression begins with untreated anxiety disorders prior to pregnancy? Big concern is up to 40% of pregnancies can be unplanned in certain populations. Any thoughts on that?
So I think we heard from the prior panel that there are clearly mental health conditions and that, prior to pregnancy, and that people bring into pregnancy, right? So about a third, I believe, is what we heard. And I think in our study, we could also see some of that in that our study window included the 3 months before pregnancy, all of pregnancy, and postpartum. And we focused on diagnoses more than symptoms, but I think it is important to recognize, we often, I think about conditions such as postpartum depression. That's what people hear most about in relation to maternal mental health. And yet, as we've been discussing today, there's a range of conditions over a range of time periods, and being aware of those types of circumstances, I think, can help with identifying appropriate treatment.
Thank you, Kara. Any other thoughts? Okay. All right, we're going to move into the next question. How are you addressing disparities and inequities in the context of opposition to DEIB efforts in many states and the denial of the existence of structural or institutional racism? That's a big one.
I mean, that is a big one, and I don't know if I can answer it with satisfaction, but I think that that's the reason that we do this work, right? Is to provide the evidence to make it about more than, an ideology, but to have facts and, like relevant statistics that show what is needed, regardless of, what other beliefs they align with.
Yeah, and I think going off of that, in addition to providing evidence of the disparities that are there, it's important to show evidence of the mechanisms as to why the disparities are occurring. So the more that we can use actual explicit measures of interpersonal discrimination and racism or structural racism, the more that we can provide that evidence base for those mechanisms.
I also think to get at this problem, it's helpful to have multiple different types of data that we can integrate. And I think this panel represents that, in that some of us are talking about symptoms, others are talking about diagnoses. But when you can put those together, you can sometimes see that groups that might have higher rates of symptoms have lower detection and diagnoses, because again, that's where the gaps in quality and disparities may exist. And we've done that in other studies. And I think it's important to continue in that vein for this very reason.
Okay, I'll keep going. There's a question that is a very good follow-up to that. In your research, what are the differences in diagnosis and treatment observed for a white woman that is diagnosed with post-traumatic stress disorder versus a woman of color that is subsequently diagnosed with PMAD?
So we did not look at treatment in our PTSD study. I think that is the logical next step that just has not been conducted yet, because there is so little information on PTSD during the perinatal period. So what we observed were just differences in diagnosis overall, because PTSD rates are higher among people with PMAD. I think that likely indicates that there are more mental health care services going towards people with PMAD already, which helps identify PTSD. So the fact that there are already racial disparities in those with an initial PMAD diagnosis, I think, is one of the reasons that we see fewer PTS diagnoses among people of color, when we would expect there to be more. So I think that it is intertwined.
Okay, we can keep going. So another attendee stated that they're aware that PRAMS uses PHQ-2 questions to ascertain depressive symptoms. Do the authors have any insight into whether this tool, excuse me, or the full PHQ-9 have been validated cross-culturally? I love this question, including with individuals who speak a primary language other than English.
Yeah, to my knowledge, the PHQ-2 has been validated in Spanish, and I believe in more recently in more diverse samples. But in general, I feel like there are major issues with a lot of the screening tools, and that they were developed and tested with white women in mind and tested among majority white samples. And so there just needs to be a lot more research investigating how these tools are functioning, and if they're actually getting at the appropriate constructs across different groups.
Yeah, and my study actually used, or in the data that I have, the screener that's used in the hospitals is the Edinburgh Postnatal Depression Scale, which is slightly different, but again, suffers from the same problems. And then also the problems of not being able to compare that to the PHQ-2. So I think there's a lot of these kind of data issues that would be, it's something that we need to work on to streamline the data, be able to understand it better.
Awesome. Thank you. That's an important question, right? Like, are we actually addressing things in a way that makes sense for the folks who are screening? Okay, so we'll go on to another question. How are these outcomes further exacerbated by, again, this DEI thing? Do you guys think that this shift we're seeing nationally is having an impact, and what strategies could be effective in continuing to push for diversity and culturally competent care among providers?
So that's certainly a huge question, and some of the data that we have is now several years old at this point, right? So immediately recent trends are not reflected in what we've been able to look at yet, but I think it's really important to keep an eye on DEI related issues, culturally competent issues, as well as other issues that we haven't discussed yet today, like changes in the post-Dobbs era and how that is affecting some of these issues. So it is a really important question for us to keep in mind. And again, we've also been using mostly quantitative research here today. I think bringing in a qualitative component would also be important, because it's hard to answer this kind of question with the checkbox type answers that you often do in surveys, or, it's not going to show up in administrative claims data, unfortunately.
Kara, I don't know if you want to explore the Dobbs decision at all in terms of the work that you're doing since you lifted it. I'm going to give you that opportunity because it was on the tip of your tongue.
Well, we're starting to look more closely at that because we have a recently funded grant from the National Institutes of Health to look at the impact of Dobbs on mental health, because I think that's also something we haven't really talked about. And, as someone past her childbearing years, it's hard for me to imagine what it would be like in this era, not just potential physical risk, but also real mental risk or just the uncertainty. So I think that's going to be an important issue that we'll continue to need to monitor over time.
Yeah, I mean, I think that what these questions are highlighting is that this is a really dynamic area where there are, things are changing constantly. And particularly, if you look at Kara's paper that shows all of these changes in all these different localities over, this 12-year span, you can see that there is a lot of movement. And I don't think that there's any reason to think that it will stop moving. So it's the kind of thing where I think we will have to continually invest lots of effort to make sure that pregnant and postpartum people are supported.
Thank you for that. So I'm going to jump to another question. This is something we've addressed a bit across the day so far, but I want to hear from y'all around the role of psychosocial support or peer support specifically within the Medicaid population.
Yeah, I can try to take that on. Well, it's not sort of part of the paper that I presented, but I do work other work on peer support in particular. And one of the sort of surveys I did in New Jersey was looking at access to peer support among by race and by ethnicity, and I found that access was actually limited in the same kind of ways that that it is for the healthcare system more broadly. So a lot of the same problems in terms of like structural things like transportation, cost in some cases. Some peer support programs are free, but some are not. So I think it's interesting that I think we kind of go to psychosocial support or peer support as like a solution for, for those who don't want to go down the road of psychiatric care. But I think there's still a lot of barriers to accessing those peer support networks. And so that is just sort of in some ways an extension of those barriers that we see in the healthcare system. So I think it's an interesting area and really important to understand how to get people to the peer support that they need, particularly again going back to that culturally diverse question around getting people to people that look like them, that have in the same neighborhoods that they feel comfortable opening up to. We heard a lot about that, and I think that's very much the case for peer support.
Thank you. All right. Go ahead. Go ahead, Kara.
Oh, I was just going to weigh in if you wanted us to say, I think that peer support in some ways can obviously be a really helpful tool for many individuals in getting to know other women in their circumstances and, feeling less alone. But it can also be challenging in the context of mental health if people are feeling a societal pressure that you're supposed to be happy and everything is supposed to be wonderful when you're pregnant or have a new baby. And maybe you're even around other mothers who are having those experiences. And so, trying to find the right sense of support among other individuals can be multifaceted, I guess is what I would say.
All right. I'm going to ask one more question and then we'll wrap. So In the questions, there's one, the screening tools research points to as appropriate for Black and diverse populations to look to measures distress. Do you think these tools in PTSD screening should be recommended in the federal government's Alliance for Innovation on Maternal Health, or AIM, release guidance for maternal mental health? And we'll wrap up here.
So I think if there's evidence that that is effective, then it would make sense to, you know, include that as a component in the measure. I'm not entirely familiar with the specific measure being discussed, but I think that it goes back to making sure that the recommendations are serving all segments of the population. And so if it makes sense to deploy it, then I think that it should certainly be included.
All right. Anyone else before we wrap? No? Okay. Thank you all so much. And we're going to move on to our next panel.
Thank you, Dr. Dillion, and to the panelists as well. Our next panel is a broad range of papers, all looking at different dimensions of improving access and care. As we bring them on stage, let me introduce our presenters. Nancy Byatt, Executive Director, Lifeline for Family Center and Lifeline for Moms Program in the Department of Psychiatry at the University of Massachusetts Chan Medical School and UMass Memorial Health. Connie Guille, Professor in the Departments of Psychiatry and Obstetrics and Gynecology and the Director of the Women's Reproductive Behavioral Health Division at the Medical University of South Carolina. Jessica Harrison is a postdoctoral research fellow at the Osher School for Integrative Health at UC San Francisco. Bridget Blebu, faculty investigator at the Lundquist Institute for Biomedical Innovation at Harvard UCLA Medical Center. Sarah Gordon, assistant professor in the Department of Health, Law, Policy, and Management at Boston University School of Public Health. And you have already met Stephanie Hall, postdoctoral research fellow in the Department of Psychiatry at the University of Michigan Medical School. Stephanie is the lead author on 2 papers, so you get 2 panels. So we'll turn again to brief presentations from each of you of your papers, and the audience can start submitting questions, and we'll take them as time permits. I'll begin. You will begin with Nancy Byatt.
Thank you. It's a pleasure to be here. Next slide, please. What I'm going to be talking about today is increasing access to perinatal mental health care, the Perinatal Psychiatry Access Program model. Next slide, please. So we know that perinatal mental health and substance use disorders are common. They occur in 1 in 5 individuals. They're undertreated, and they're a leading cause of maternal death in the United States. And we might all be wondering, well, why is that the case? I know today I've been discussing a lot of the reviews, and I'm going to present sort of a model right here that talks about it's because we don't have enough clinicians available to see them, among many other reasons. So on this slide, if we consider an obstetric practice, say, for example, this obstetric practice is serving 1,000 individuals. Of those, if 1 in 5 are going to experience an illness, we're going to have 200 in that practice that have mental health symptoms. Of those, let's say that 150 of them, treatment is indicated. Of those, let's say that 125 accept a referral. And then of those 125 that accept the referral and need treatment, there's typically not 125 clinicians available to treat them. So you have a situation where you have the dearth of available clinicians to see the people that need a clinician, and you have people waiting for treatment. And while people are waiting for treatment, we see negative outcomes, including maternal mortality. Next slide, please. What the Perinatal Psychiatry Access Program model does, which I'm going to shorten to Access Program model, it aims to increase access to perinatal mental health and substance use disorder care through workforce development. So rather than having, these 125 individuals that are circling, waiting for treatment, because in all of our lifetimes, there will never be enough professionals available to see them, unfortunately, not in our traditional models that we've been using over time in our country. Rather than doing that, instead, what would happen would be it's identified that somebody needs treatment and support. They can consult with the access program. They can help build their capacity to provide that treatment themselves. The obstetric clinician treats the patient, and there's no wait for treatment. So rather than circling around, we build the capacity for others to treat these illnesses themselves, and thereby increasing access to care. Next slide, please. In this particular study, we surveyed at the time, there was 15 perinatal psychiatry access programs across the country. We did the study in June of 2020, and we asked them, what are the components by which your programs are implemented? Because we wanted to understand how is this being implemented across the country, because it's been rapidly disseminating, which I'll come back to soon. And what we learned, but there's 5 components. The first being training and toolkits, so doing grand rounds at birthing hospitals or practice level trainings. Many are using the ECHO model and providing toolkits. The second is phone consultation, whereby if, for example, an obstetric clinician is seeing a patient and they're not sure what to do, they're not sure how to respond to a positive screen, they can call, they can speak with a psychiatrist who helps guide them in providing that care themselves and holds their hand in that process. All the programs did telephone consultation, and 86% provided training. Half of the programs, 50%, were providing also the third component of direct service consultation. In this component, if during that phone consultation there's still a question, these programs are providing a one-time consult where they're seeing the patient, they're providing recommendations back to that obstetric clinician. The fourth component that we heard in these interviews and was resource and referral, and 71% of the programs were providing this. This is where if during that phone consult therapy is indicated, they link the patient with resources in the community. Therapy is first-line treatment, certainly for mild illness, and often this is provided without any medication treatment, as should be the case. And then the fifth component was technical assistance. Half of the programs across the country were providing this. This is where the access programs go into an OB practice and really help them integrate mental health care into their workflow. So it's a part of their workflow, just like diabetes. We never screen a patient for diabetes and not follow up and make sure their blood sugar is under control. So really working with obstetric practices to make sure it's really part of their workflow. Next slide, please. And half of the programs were providing technical assistance. The other thing we learned as we did these interviews with these 15 access programs across the country was that they are really tailored and to each state. Each state has its different culture, it's serving different populations and has different levels of resources and political environment. So there's a lot of tailoring that happens, and we saw a lot of variation in how these program components are implemented. This is exciting in that it creates innovation. At the same time, it's challenging because we don't know which implementation strategies work best. Next slide, please. And really what we were aiming to do in this study was to understand, of all the access programs, what are the access program components? And the goal is that then helps us begin to develop an evidence base for how are they best implemented. So we now have 29, almost double than when we did the study less than 3 years ago now. And we have almost 4 years ago, and we have 29 regional or statewide access programs across the country. Together, these programs have the potential to cover 2.5 million or 68% of the 3.7 million births in the US every year. And, I say potential to cover because many of these access programs, we also heard in this study was that many of the access programs are struggling with utilization. They open up, it's not a you build it, they will come. They find that it's hard to get people to call, and it's hard for these access programs to engage the professionals they're aiming to serve. I love the implementation science model, the RE-AIM model, which talks about impact being a function of reach and effectiveness. We have effective evidence-based interventions for mental health and substance use disorders. The goal is to increase the reach of those interventions. Next slide, please. And I'm going to conclude by making a parallel to childhood cancer. And that, operationalizing access program components are a needed step towards thinking about how do we best and most effectively implement these programs and other programs like it across the country that are population-based. So ALL, acute lymphoblastic leukemia, is a childhood cancer that in the 70s had a 90% death rate. They brought people together nationally and they looked at how do we better implement this care, and now has a 10% death rate. We have a similar opportunity and issue with perinatal mental health and substance disorders. People are dying at increasing rates. We have treatments that work, so we need to get them to people. If you could click through, please. And the goal is that by doing this, we can, by these systems level interventions, of which there are many, and doing that with an equity focus as we've heard about today, we can increase access to care and have more positive outcomes. And I'm deeply grateful, next slide please, to the many people who've been involved in this study, and particularly to the lead author, Anna Schaefer, who led the manuscript. Thank you.
Thank you very much. We'll now turn to Connie Gill.
Great. Thanks so much. It's a pleasure to be here. I'm going to switch gears and talk really about the first part of this is just screening and identification of maternal mental health conditions and access to care. Our work has been focused on trying to build different systems of care that overcome the many barriers that we've already discussed today in creating effective screening, identification, and access to mental health and substance use disorder care for pregnant and postpartum populations. If you go to the next slide. I'm going to tell you a little bit about the system that we created, but for this paper, essentially what we did is a randomized controlled trial comparing that different system of care to usual care for screening, referral, and access to treatment. We conducted this study in a large healthcare system in the Southeast, really because it was kind of a closed system where we could collect all our outcomes via an EHR data collection for participants that were being screened for mental health conditions during pregnancy and the postpartum year, those that were screening positive, being referred to treatment, and also attending treatment. We looked at a system that we built that's called Listening to Women and Pregnant and Postpartum People that was really developed out of qualitative research. And how that differs from usual care is essentially when a pregnant or postpartum individual comes into prenatal care, they would be enrolled in the program. They are receiving the screening questions, those validated screening questions for mental health, substance use, and intimate partner violence via text message. They can complete those screens on their phone or their email. If they endorse elevated symptoms, or they screen positive, a care coordinator that has a master's in clinical social work would reach out by phone and conduct that brief assessment, do a brief intervention, and if appropriate, referral to treatment. Both groups in this study, the referral to treatment was to a practice that was co-located within that OBGYN practice and included a psychiatrist, a psychologist, and therapists within the OBGYN practice. How that's different from usual care is essentially we typically just screen people verbally with asking the same questions sort of face-to-face, usually by an RN. If people are screening positive, it's usually the prenatal care provider that's doing that brief assessment and that intervention and referral to treatment. So in this randomized controlled study, people were randomized to this Listening to Women and Pregnant and Postpartum People or usual care. Go to the next slide. Thanks. This is just to say that there were really no group differences in terms of demographics between those assigned to Listening to Women intervention versus usual care in terms of age, income, a whole host of variables, including current depressive and anxiety symptoms. Next slide. Again, just highlighting no differences between these two groups in terms of race and ethnicity, the rurality of their residents, and their self-reported diagnosis of mood or anxiety or substance use conditions. Next slide. So here are our primary outcomes, just to orient you. The dark blue represents the people that were assigned to the Listening to Women intervention. The light blue are those that are assigned to usual care. And as you can see here, there is a much higher proportion of women that assigned to Listening to Women in comparison to usual care that were 3 times more likely to actually complete a screening for these conditions. They were 9 times more likely to screen positive for these conditions, be referred to treatment, and attend treatment. Next slide. I think it's important to note that if you didn't complete a screening, you weren't eligible for these subsequent outcomes. So we looked at our data just by people that actually completed a screen in Listening to Women versus usual care. And what we see with those assigned to Listening to Women, they're 3 times more likely to screen positive for mental health, substance use, or intimate partner violence. They're 4.4 times more likely to be referred to treatment and about 5.7 times more likely to attend mental health treatment. Next slide. We've heard a lot today about a lot of the racial disparities in screening and access to treatment. So we wanted to look at our results by what was a larger population in our cohort of Black non-Hispanic individuals. And what we see in this group as well is the same thing that was reflected in the overall study is that if you were assigned to Listening to Women, you were 3.1 times more likely to be screened, 11 times more likely to screen positive in comparison to that face-to-face usual care screening, more likely to be referred to treatment, and more likely to attend treatment. Next slide. And then similarly, we know that often in rural areas, it's really accessing treatment is even more difficult. So we wanted to look at our data by that subgroup as well. And again, just across the board, seeing that this tech-based system is improving the rates of being screened, screening positive, being referred to treatment, and attending treatment in comparison to usual care. Next slide. So just as a brief summary, we see that overall, compared to usual care, those participants that were assigned to this intervention were 3 times more likely just to get a screening complete. Among those that were being screened, those that were assigned to listening to women in comparison to usual care were 3 times more likely to screen positive, more likely to be referred to treatment, and about 5 times more likely to attend treatment. And these findings seem to be consistent in Black, non-Hispanic, and rural and partially rural populations. I think what this overall and overarching sort of represents is that we have for a very long time been trying to get screening and referral to treatment implemented into clinical practice and meeting a lot of barriers. And we really need to think about different systems of care and using something that's very simple and easily and readily available to people like their phone seems to be a good way to do that. So I think that these data support that, and what we sort of want complementary to that are support through insurance payments to be able to support different and alternative systems of care that work, and policies that also support adoption of that in clinical practice. I think we need continued efforts in digital literacy and just in everything that we're doing, given that so much of our work is delivered via telehealth these days. And so continuing to support that among communities as well. And so I will stop there. Thank you. Oh, last bit, I would really like to acknowledge, obviously, the participants taking part in the study and our Women's Reproductive Behavioral Health team and the other infrastructure that we have available to us, including our funders. Thank you.
Thank you. I'll turn it over now to Jessica Harrison.
Hi, everyone. Thanks so much for having me. I'm glad to be here to share in the celebration of this special issue. Next slide, please. I'm a sociologist and a qualitative researcher, and I wanted to understand how clinicians and patients experience mental health integration efforts in perinatal care. So to study this, I spent over 2 years observing a mental health team that was embedded in a large perinatal care organization in my community. And I conducted in-depth interviews with mental health clinicians in these settings, nurse midwives, and obstetricians. I also longitudinally interviewed 25 pregnant and postpartum people about their experiences with mental health in the context of their perinatal care. These data aren't in this particular paper, but I mention it because it's always relevant to my analyses. I'm happy to talk more about methods in Q&A if people are interested. My study was developed prior to COVID and conducted almost entirely during the acute phases of the pandemic, so it's a significant backdrop of my work. And briefly, before I talk about what I found with clinicians, I want to set the stage. A lot of you here may be familiar with mental health integration in perinatal care, but it's important context. So the mental health teams in these settings typically consisted of 7 to 12 clinical social workers, professional counselors, and psychologists who provided the bulk of mental health care in the clinic or by telehealth, usually in 30 to 50-minute individual appointments. They also had typically one psychiatrist or psych nurse practitioner who is part of the mental health team, and these folks mainly provided complex medication management for pregnant and postpartum people. Referrals into these teams were generally based on the discretion of nurse midwives and obstetricians. The mental health programs were mainly supported by insurance reimbursement for billable services, but there were some outliers, some cases when organizational funds were used and short-term grants as well. And then the last thing I'll note is that mental health team staffing was pretty unstable over the course of my research. It changed many times. Next slide, please. So what I learned from midwives and obstetricians in my study will probably come as no surprise, that addressing patients' mental health is challenging and uncomfortable. They universally recognize the importance of mental health, but they face numerous barriers in addressing this, mainly lack of time in the clinical encounter, a lack of confidence that they had effective strategies to address their patients' mental health got in the way. Also, what we have to keep in mind about perinatal healthcare in the United States is the risk paradigm that defines it. So every pregnant person is always already at risk in this model, and bringing mental health into the arena of perinatal care expands the terrain of risk for already overwhelmed clinicians to navigate. So when mental health clinicians were then integrated into the perinatal care settings, it brought relief to nurse midwives and obstetricians. These participants all expressed gratitude to have access to mental health in the clinic because it really did smooth their path to supporting their patients' mental health. What I found, though, was a transfer of problems onto mental health teams. And this is because the system we're working with is under-resourced to begin with, and it's not well designed for mental health. So when mental health teams were established in perinatal care, there was very quickly an influx of referrals. So for example, the team I observed would receive about 30 referrals a day, and they had a wait list of about 80 people. So they routinely talked about feeling overwhelmed by their workload, which included managing their caseloads and responding to warm handoffs initiated by midwives and obstetricians. And so over time, they worried about the quality of care they were providing, and they talked about shorter appointment times and many weeks between patient appointments. They also described a tension between what they perceived to be a worthy referral versus what they received from their colleagues. One of my participants explained that their definition of a mental health crisis is different than mine. So this really brings up a key puzzle in our collective quest to address people's mental health, which is what constitutes a mental health issue requiring specialty mental health care. Mental health clinicians' workload was also challenged because of their positionality in the clinic. There is an established hierarchy within the organization of healthcare with medical authority at the top and others like mental health clinicians positioned as secondary experts. So the mental health clinicians really perceived they were obligated to respond to perinatal health clinicians' requests, even if their clinical judgment may have led them to a different conclusion about a person's needs. So then the last thing I'll note here in the results of my study is that the COVID-19 pandemic was a catalyst for change as mental health care migrated to telehealth. The team I observed implemented a referral protocol at this time, and it clarified their role and provided some boundaries for the team. But then in turn, it reduced access to the care they provide. So I can talk more in the Q&A about this and the competing needs inherent in mental health integration if folks are interested. Next slide, please. So in my paper, I mentioned a number of incremental approaches to improving the model we have to better support people's mental health and the sustainability of clinicians' work. You can look there for more details, but these are things like expanding the use of group-based care, developing community-based postpartum care, reducing administrative burdens, using telehealth. I also think we should reconsider how we define mental health in the perinatal period and really challenge this persistent mind-body dualism that's prevalent in health professions education especially. But the main and last thing I want to say, and I think reiterate as I'm hearing this come out in other folks' conclusions about practice and policy for perinatal mental health, is that our healthcare system and the predominant obstetric model of care are not well designed to meet the multifaceted needs of pregnant and postpartum people. And as we all know, clinicians are not faring well in this system either. So I really want to encourage us to think critically and act carefully as we consider expanding integrated perinatal care in the status quo system. So I'll leave it there and say thank you so much for your time. I'll look forward to talking further.
Thank you. Now over to Bridget Blebu.
So today I'll be sharing some findings from a cross-sectional study on the co-occurrence of social determinants in people with perinatal depression, anxiety, or serious mental illness. Next slide. So it's well established that many social determinants of health are associated with an increased risk of depressive symptoms, anxiety, and serious mental illness in pregnancy. And because of that, screening for social determinants throughout the perinatal period is increasingly endorsed. However, despite this evidence, many studies don't actually examine the co-occurrence of adverse social determinants, particularly in people who are experiencing a serious mental illness. And this is an important gap because research that evaluates the co-occurring social determinants in pregnancy, especially when considering diverse populations, could actually reveal important patterns that may inform person-centered approaches to addressing stress in pregnancy. So we conducted a latent class analysis using indicators of social determinants listed here, as well as substance use, which included alcohol and drug use. We used data from a comprehensive needs assessment conducted at prenatal intake for over 8,000 racially and ethnically diverse clients who received care at the Los Angeles County Department of Health Services in California between 2017 and 2020. Next slide. So after conducting the latent class analysis, we identified 3 distinct subgroups of co-occurring adverse social determinants and 1 subgroup of single or no social determinants, which reflected reports from majority of the clients. We characterized subgroups based on similarities in the likelihood that each indicator would have been endorsed by clients at intake. So for example, the first subgroup denoted in yellow was characterized as having the highest endorsements of socioeconomic and interpersonal factors like housing instability, intimate partner violence, and low social support. Overall, those with a positive screening for depression, anxiety, or a serious mental illness were more likely to experience a co-occurring social, be a part of the subgroups, one of the three subgroups. So for instance, compared to those without any mental health issues, clients with a positive prenatal screen for depression or anxiety were more likely to experience a co-occurring socioeconomic and interpersonal factors or co-occurring substance use and interpersonal factors like intimate partner violence and a history of drug use. And clients with a serious mental illness had a much higher reports of experiencing several determinants across all domains. So these findings complement existing research on the associations between social determinants and perinatal mental health, but they also highlight differences in patterns for those with serious mental illness, which may shift how we improve care for this particular population. Next slide. And given that marginalized racial and ethnic groups are more likely to experience poor perinatal mental health, we also examined the co-occurrence of social determinants broadly by race and ethnicity in the sample. And interestingly, we found that Black and Hispanic clients were less likely to report experiences of co-occurring social determinants compared to their white counterparts. This pattern may be capturing differences in reporting at intake, where marginalized groups may be less likely to share multiple adverse social determinants for fear of discrimination, provider bias, stigma, lack of trust, or even just a desire to prioritize support for their most pressing need. So ultimately, we felt that these findings really stress the importance of solutions to improve trust in healthcare settings, including building more diverse collaborative care teams that reflect the communities being served. And lastly, screening at multiple time points, especially once trust and rapport is established, may be beneficial, as well as building capacity in community settings beyond healthcare to address perinatal mental health could improve patient care as well. And next slide. Yeah, so those are a very brief summary. I think you can find a lot more in our paper included in the special issue. I do want to acknowledge my colleagues at the Los Angeles County Department of Health Services. Thank you all for your attention. I look forward to the discussion.
Thank you. And now I'll turn it to Sarah Gordon.
Hi, everyone. Thank you so much for having me. I'm going to be talking today about our paper titled Extended Postpartum Medicaid Associated with Increased Treatment for Perinatal Mood and Anxiety Disorders. Next slide, please. I want to acknowledge the funder of this work, the National Institute of Mental Health, and also our partners in Colorado, without whom we really couldn't have done this project. And then I also just want to note that I also work for HHS, and everything I'm presenting today does not reflect the official views or policy of the Department of Health and Human Services. Next slide, please. So our study question that we were hoping to answer with this analysis was whether extending Medicaid coverage after birth increases use of treatment for postpartum mood and anxiety disorders. And there were several reasons that we were interested in this question. The first is that we know that postpartum mood and anxiety disorders occur at higher rates among those of lower incomes who are disproportionately insured by the Medicaid program. And the American Rescue Plan Act in 2021 provided states an option to extend Medicaid coverage from the federally mandated 60 days of coverage after birth for people who are eligible because of their pregnancy to a year after birth. And as you can see in the map, this policy has been rapidly adopted. There's only a handful of states that have not implemented this policy at this point, but we really don't have a lot of evidence on the effects of this policy on key healthcare utilization and health outcomes that we'd be interested for this population. Next slide, please. So our study setting focused on Colorado specifically from 2014 to 2019, and we focused on this time period because we did not want our study to overlap with the pandemic, during which there were other national policies which prevented states from disenrolling people from the Medicaid program, which would have made it very difficult to evaluate the coverage effects of postpartum Medicaid insurance. So in our study, we used a natural income-based experiment in the Colorado Medicaid program to compare the effects of Medicaid coverage versus transitioning to commercial insurance after birth. So in this diagram, you can see on this slide, everyone in Colorado is eligible during this time. Colorado is one of the states that has since extended pregnancy-related Medicaid eligibility out to a year. But during our study period, everyone with an income below 265% of the federal poverty level was eligible for Medicaid from their conception through 60 days postpartum. But at that 60-day time point, only those with incomes below 138% of the federal poverty level could retain Medicaid coverage. And if you were above that, above 138% FPL, you would either have to find a commercial insurance plan or become uninsured. And so this basically means that for a family of 3 with an income of about $70,000, you're covered during your pregnancy, but only if you have an income under about $35,000 can you retain that Medicaid coverage at that 60-day time point. So that's a big jump. There are a lot of people who fall into that gap. And so we use something called a regression discontinuity study design. And the intuition behind it is that if you compare people on either side of this income cutoff, it can be used as sort of as a form of random assignment to compare the effects of one type of coverage versus the other. So if you proceed to the next slide. So this figure is from our paper, and you can see that the vertical dashed line is that 138% FPL income cutoff, which separates Medicaid eligibility after birth. And this figure shows the probability of experiencing outpatient mental health treatment in the postpartum year. And so this looks at actual treatment rates. And this was among everyone. We didn't restrict specifically to those who had a diagnosis. So this is just among our entire sample of Medicaid births in Colorado. And so you can see that at that line, there is this sharp decrease. So those with incomes below 138% FPL who could retain their Medicaid after birth had higher rates of outpatient mental health treatment, and those above the 138% FPL threshold had lower rates. And so in our regression models, we find that remaining in Medicaid versus enrolling in commercial insurance was associated with a 7.3 percentage point increase in outpatient mental health care and $40.84 lower out-of-pocket spending per outpatient mental health care visit. Next slide, please. So this figure is very similar to the one on the prior slide, but now we are looking at the probability of a fill for a prescription medication for depression or anxiety. And so here we see a similar but stronger story. We see stronger effects for prescription medication as opposed to outpatient care. So we see that remaining in Medicaid versus enrolling in commercial insurance was associated with a 16 percentage point increase in prescription medication for anxiety or depression, a $3.24 lower out-of-pocket spending per prescription fill. And when we looked at continuity of treatment over time, so that's 3 outpatient visits or 3 fills of a prescription, we found an 18.7 percentage point increase in continuous mental health treatment in the postpartum year for those in Medicaid versus switching to commercial insurance. Next slide, please. So I think our findings could be explained by a few different factors. So one is that there's evidence showing that when people lose their Medicaid eligibility after birth, this can cause gaps in insurance, which reduce access to mental health care. When people do switch to a different plan, if you're switching from Medicaid to a commercial plan, you may have to take time to establish care with new providers. It may take a while to find a mental health provider that will take your insurance. And then lastly, as we show in our study, people are also exposed to higher out-of-pocket spending in the commercial plan as opposed to Medicaid. And so this can be quite a barrier because this is a fairly low-income group, all under 265% FPL and eligible for Medicaid during their pregnancies. So our findings indicate that staying on Medicaid instead of enrolling in commercial insurance after birth may lower barriers to postpartum care. Next slide. And so in terms of policy implications and thinking about what the implications of these findings are for the states that have implemented postpartum Medicaid extensions, our findings suggest that these extensions may increase receipt of PMAD treatment and lower out-of-pocket spending for mental health care. and that these extensions may have important benefits for postpartum mental health, a leading cause of morbidity and mortality. However, I just want to say that this coverage is just a first step, right? And so sort of a necessary but insufficient strategy to address the overall burden of postpartum mental health. Next slide. Thank you.
Great, thank you. And we'll close the panel with Stephanie Hall.
Well, hello. Again, my name is Stephanie Hall. I'm a postdoctoral research fellow at the University of Michigan. And I'm also the lead author for this study, which assessed an increase in antidepressant prescriptions for privately insured people with perinatal mood and anxiety disorders between 2008 and 2020. Next slide, please. So we know that perinatal mood and anxiety disorders, or PMAD, are very common, affecting 1 in 5 delivering people. And we know that PMAD symptoms range from mild to life-threatening. Now, there are a variety of safe and effective treatments available. Among these, antidepressants are often a first-line treatment due to the ease and accessibility of prescription medication compared to some other treatment modalities. Now, despite the widespread availability of antidepressants, PMADs are frequently undertreated. And not only are PMADs undertreated, they're often underdiagnosed. Next slide. So, to address underdiagnosis, between 2015 and 2016, 3 major organizations issued screening guidelines. And these guidelines generally recommended universal screening for depression symptoms at least once during pregnancy and postpartum. So what do these guidelines have to do with antidepressants? Not much, actually. These guidelines don't specify or recommend specific treatment regimens. Instead, they generally advocate for proper follow-up care for those who screen positive. Because the idea between universal screening strategies is that if we identify PMAD symptoms, then diagnosis and treatment will follow. And there's certainly evidence that that's true for increasing diagnosis rates. But we wanted to take it a step further and test whether screening guidelines could also increase treatment rates. So we used commercial insurance claims for 120,000 delivering people with a PMAD diagnosis who delivered between 2008 and 2020 to test whether there were changes in antidepressant prescriptions. Next slide, please. So in this figure, you can see the percent of PMAD patients who received an antidepressant each year from 2008 to 2020. We looked specifically at those with a PMAD diagnosis during pregnancy, and that's the blue line. During postpartum, that's the yellow line. And those with a PMAD diagnosis during pregnancy or postpartum, and that's the red line. So you can see that in all cases, the percent who received antidepressants decreased steadily from 2008 to 2016, followed by a sizable increase in 2017. And then from 2017 to 2020, it largely stabilized or possibly increased. So it's interesting to note that you can see this effect is more pronounced in that blue antenatal line. That's the group that had a PMAD diagnosis during pregnancy, which is interesting because antenatal mental health is often overshadowed by postpartum mental health. And so it makes one wonder if the guidelines help to counteract this myth. And I do want to note that we did multiple sensitivity analyses to assess alternate explanations that might have caused this increase during this time period, including looking at the Mental Health Parity Act, ACA, changes in coding, and changes in antidepressant generics and warning. But we couldn't see an alternate explanation, and the most pronounced effect coincided with these screening guidelines. Next slide, please. So our findings are consistent with our hypothesis that screening guidelines may have had ripple effects on downstream care. And how do the guidelines do this exactly? Well, because we're looking at a very high level, it's difficult to say which mechanism is at play for sure. But the guidelines could have addressed some very common barriers to maternal mental health care, like lack of knowledge and stigma. And the rapid issuance of so many guidelines at such a short period of time may reflect an overall clinical and cultural shift, as well as new resources ramping up to better support mental health in pregnant and postpartum people. So we note that that prescriptions in general are likely an especially sensitive marker to these kinds of effects because they are relatively easy and inexpensive compared to other treatments. However, the implication is that if we can apply a systems approach and strategically stack or snowball, more simple clinical interventions like screening to achieve downstream care like antidepressant treatments, then we can better design clinical guidelines to both minimize provider burden while improving care. Now, this is not to say that screening is a panacea, but these results do indicate that simply starting these conversations about mental health symptoms with a care provider may have helped trigger follow-up care. Next slide, please. And so to learn more about this study, you can read our full article on Health Affairs. And again, a big thank you to my team and our funders at NIH. You can learn more about us and our work at the link on your screen.
Thank you, and thanks to all of you for concise and comprehensive presentations. So we grouped these all together, but obviously they cover a broad range of topics. One thread that seems to me to run through many of the papers, though not all of them, has to do with the different roles of different professionals in the perinatal mental health care system. And Dr. Harris, in your paper on sort of the limitations of integration as the perfect model here really stand out. But that said, we have papers here describing improving, expanding capacity for the medical workforce. We have papers looking at the role of care coordinators in improving screening and referral. The paper on social determinants, it raises the question of who within the care system is responsible for identifying and also addressing these. So I'm hoping we can have, rather than sort of a paper by paper conversation, I'd love to have a few minutes, I know we don't have a lot of time, but a few minutes of conversation about how do we, given that the opening panel talked so much about the different perspectives that each of them brought and the need for a multidisciplinary team, and yet the barriers in engaging a multidisciplinary team, sort of what are the next steps here from the perspective of your work? How do we build capacity, but also teamwork capacity to achieve what it seems is needed for better outcomes? And I know it's a broad question, but I'd love to hear some thoughts about that. Whoever wants to kick us off.
I don't mind trying to. It
Please.
is a really big question, but I really think that the problem is multifactorial across the board. So we really need multi-level interventions to address all the different problems. And so when you sort of try to tease it apart, I think breaking it down into the individual patient, individual provider, and system level barriers, and sort of systematically working through the different needs, which are going to be different from different practices and different settings. But I think it's really starting out with a very clear understanding of like, what are the barriers to making effective screening and treatment happening in a microcosm or in even a bigger group. And then systematically applying different tools. No one tool is going to fix this. We need all of these tools, and it's just about applying them in the right way, in the most efficient way. That's the best I can do.
Great start. Anyone else want to jump in?
Yeah, I can build on that. I totally agree
Great.
with what Connie just said. And I think we absolutely need multi-component, multi-level interventions. And I agree with the systems. I think that in my experience, I didn't talk about this in our talk, but we do a lot of implementation work with both at the state level with access programs and also with OB practices. And in my experience, when we think about implementation, it's one size fits none. In that, just like Connie was saying, you develop something that works in one setting and you can't possibly assume it's going to work in another setting, because each system, each state has its ecosystem, its culture, its values, it's always different. So I think when we think about scaling anything to do with access and making change at a systems level, we have to tailor things. And I think we need sort of interventions that are multi-component, like Connie said. And I think in addition, we have to build into that implementation. How do we tailor that so that we're meeting the values, the needs? And like, for example, we've heard a lot about, the focus today on equity and on, adverse social determinants of health. Those differ also. So how do we sort of tailor that to make sure that we're doing that with a lens when we're focusing on making sure that we're not meeting the need? If we focus on the needs of everybody, then we may actually exacerbate inequities, right? Because we increase access for everybody, and then the marginalized groups have even less access, when we compare them to the other populations. So I think in doing that with that lens, and I think bringing different disciplines together to be doing this together, because often this is happening in silos. And so thinking about how do we have people that aren't like thinking of non-traditional models to increasing access. And you don't have to, like, for example, you don't have to be a therapist to be therapeutic. Who else can be providing therapy? And not everyone can be referred to a PhD psychologist. That would be lovely. It's not going to happen in any of our lifetimes that everyone can access that, particularly with our hierarchical medical system and access system we have in the United States.
Yeah, I want to just jump in right off of that, because I think a lot about de-siloing. And I think what we have to maybe step back and think about together is that people's pregnancy experiences, people's perinatal experiences are deeply impacted by their healthcare experiences. I mean, this is like the first time so many people are showing up in healthcare, and there's a lot of it. And so looking at how that, right, or the predominant obstetric model of perinatal care in the United States has to change. That, I think, when we really think about broadly influencing people's mental health in the positive through the perinatal period, re-evaluating how we are delivering care, especially because we're saying this is a holistic experience for people. This is a physiological moment, but it's so much more than that. And we in this room are actually saying mental health is one of the biggest things that's impacted in this period of time. And so why aren't we starting there, right? And so that's what, when I talk about sort of challenging this mind-body dualism, thinking about how that's showing up in health professions education, thinking about the way we're actually delivering perinatal care. And I know I'm talking about really big things here, but I want us to talk about those things. And I want us to really take a bird's eye view and see how the actual delivery of perinatal health care is directly connected to people's mental health.
Yeah, those are excellent points. And I think to add to that, thinking broadly, even beyond sort of the healthcare system, because I think a lot of Jessica's work did show that there are systemic barriers as far as lack of time. And as far as social determinants go, like what does it look like for perinatal mental health screenings to be happening at a WIC office or some other community-based organization or resource, so that the wraparound experience is not just happening within the healthcare system, but is also sort of integrated outside of that. So.
Well, let me, I really appreciate those answers, and I'll just expand out a little bit. Beyond the coverage dimensions that Sarah Gordon's paper talked about Medicaid, of course, Medicaid is the payer, the dominant payer in this area. And so we talk a lot about the roles of the clinicians and the mental health clinicians and the OBGYNs. We haven't talked a lot about the role of payers in building any of this model. And I wondered what you could see, not just in terms of payment policy, although that's one option, but sort of more broadly, is there a role for Medicaid and potentially the commercial payers as well to help support the development of the kinds of models of care that you think would be effective? I see some nodding heads, but I wonder if anyone wants to explain what that role might be.
I can happy to comment on this. So the challenge with thinking of so starting with the medical system, the challenge with thinking about this with perinatal care is that OB care is a bundled payment. And so there is no financial incentive for obstetric practices to provide mental health care. And actually they can't, it's very, very challenging. So, and then when we think about, that's one piece. So when we think about, I totally agree with what Jessica said around thinking about this holistically. And if we really think about, having mental health care be part of care because it's a leading cause of death, and we know that we can improve outcomes with thinking about this in a less dichotomous way, that it's the whole person, including their brain. And in order to do that, we need to be reimbursing people for doing that work and have payment models that actually incentivize that, or make it so that practices can make that financially viable, even regardless of incentives. And so, for example, the bundle payment's a challenge. And also when we think about community interventions, like Bridget, you were saying, doula care. We just passed a law in Massachusetts where doulas get reimbursed. They're not getting reimbursed enough, but it's a good step. It should be more. But like thinking about reimbursing models where it's not a traditional medical model. So reimbursing community resources, reimbursing integrated health, reimbursing the access program model that I described. In our state, the commercial payers pay a surcharge for that program. It's funded by the state, and the payers pay a surcharge. They pay for 50% of the program, which is proportional to the amount they're insured. So that's a model that I think ours is the only state that has it, but that's one model. But we really need to be reimbursed to provide that care so it's more holistic.
I'll also just, I agree with everything Nancy said. I'll also add, though, I do a lot of research on the effects of postpartum Medicaid extensions, and, it's a real policy success, right? Like this has been rapidly adopted, and it's a pillar of sort of the maternal health improvement, like strategy at the federal and state levels. And I think that that's really important, but I'm always very careful to say that like 10 months of coverage is like not going to fix this, right? It's very incremental, and that tends to be how progress moves forward in our healthcare system. But there are now, because we sort of have coverage now nearly nationwide as a baseline, what needs to happen next on the payer side, right? And so are there, to Nancy's point, specific services to unbundle, to recreate incentives? And we've seen states doing this around LARCs, or specifically focusing on other quality indicators. And I think this is also really relevant when we think about value-based healthcare transformations in general. Like if you think about ACO models, which are rapidly adopted in Medicaid, is that the right model for the pregnant population, particularly in Medicaid? A lot of them come in to Medicaid for the first time because of their pregnancies. Suddenly, a PCP is that attributed to that patient, and they're responsible for their care as part of this value-based contract. And so I think we need to be more imaginative about sort of thinking about this population in ways to really design like specific value-based payment incentives, and both on the Medicaid and commercial side. But I think there's a lot of opportunity in the Medicaid program, given sort of the emphasis on maternal health. To pay for things like doula services, to pay for group prenatal care, to pay for postpartum home visiting, right? There's lots of examples of these, and to really, build evidence around those programs so that there can be like lessons shared across states and encourage adoption of things that work.
Well, as we come to a close, I want to do three things quickly before I thank you. One is to note that one member of the audience asked about including social workers in perinatal in the access program. So I just want to put that out there. I thought that was interesting. I also want to read, you never know who's going to be in the audience, but I want to read this directly as it was sent in. This person wrote, as the clinical quality measure developer for clinical screening for depression follow-up, which is often noted as the only HEDIS measure related to perinatal mental health. The idea was to screen and initiate follow-up care. A subsequent measure that was never developed was an outcomes measure looking at treatment adherence and symptom resolution. In an era of practicing to measures, providers' care delivery expectation is truncated to referrals and medication management. So I had never heard before that the intention was to have a second indicator that had much more to do with the long-term follow-up and not just on screening and diagnosis. The last thing I will say is I'm really glad that Sarah Gordon brought us back to the Medicaid expansion as a policy success. You know, if we had this event a few years ago, and indeed we did, top of the list is expanding Medicaid eligibility postpartum. And here we have it, and it was optional, and yet it has been roundly adopted by essentially every jurisdiction in the country. And so in a community that tends to often ask the question, you know, what is the next thing to do and what is the problem we need to solve, it is really worth it to take a moment and celebrate a major policy success that dramatically expanded coverage. And although, as you noted in your comment, it doesn't solve the delivery system problem, it's probably a necessary precondition for it. And so we ought to make sure we celebrate our successes even as we continue to discuss what needs to be improved. So I'm glad you brought us back to that. With all of that, again, thank you all. I know we're doing this in very on a very tight timeline, but appreciate your work and your presentations. And I'm now going to move us into our third panel, which will look at solutions focused on a variety of targeted populations. I'm pleased to hand the moderating function over back over to Dr. Bridget Blebu, who was on the last panel. Dr. Blebu, I'll let you take it from here.
Thank you. So I'll go ahead and introduce our next set of panelists. I'll start with Nicole Goodsmith, who is an assistant clinical professor at the Department of Psychiatry and Biobehavioral Sciences at the David Geffen School of Medicine and a psychiatrist and core investigator at the VA Greater Los Angeles. Tova Walsh, associate professor at the Sandra Rosenbaum School of Social Work, University of Wisconsin-Madison. Sandra Luz Lara-Cinisomo, associate professor, Department of Kinesiology and Community Health at the University of Illinois. And I will pass it over to Nicole Goodsmith.
Thanks so much, Bridget. It's really a pleasure to be here and to follow such great presentations. So I'm Nicole Goodsmith. I'm a psychiatrist and health services researcher at UCLA and the Greater Los Angeles VA. And as such, standard disclosure that the views expressed in this presentation are those of the authors and do not necessarily reflect the position of the Department of Veterans Affairs or the United States government. So our article is called Addressing Pregnancy and Parenting in Mental Health Care, Perspectives of Women with Serious Mental Illness. And this study was funded by the UCLA VA National Clinician Scholars Program and was conducted during my time as a fellow in that program. Next slide, please. So women living with serious mental illness are at increased risk for pregnancy complications like preterm birth, as well as negative parenting outcomes like custody loss. And so there's really a need to ensure that women with serious mental illness have access to support and information around healthy pregnancy, pregnancy prevention, and parenting. Now, for many people living with serious mental illness, outpatient mental health clinics are their main point of contact with the healthcare system. So mental health clinics offer a potential opportunity to support women in pregnancy and parenting, including planning for and managing psychiatric medications during pregnancy and postpartum, as well as addressing parenting and custody challenges. And so for this study, we partnered with the Los Angeles County Department of Mental Health, a large safety net mental health system serving individuals living with serious mental illness. Leadership there, including my co-authors, Drs. Emily Dossett and Rebecca Gitlin, wanted to hear directly from patients about how to best approach efforts to integrate reproductive services into routine mental health care. And it was important to us to ground this work in a reproductive justice framework, as you've heard about in many of the other presentations today. In our case specifically, reproductive justice helps us to consider how historical and ongoing reproductive control and coercion of women with mental illness may affect their experiences of pregnancy, parenting, and mental health care. In our exploratory study, we interviewed patients to learn more about how women living with serious mental illness view discussing pregnancy and parenting with their mental health providers. We conducted qualitative interviews with 22 reproductive age cisgender women patients from 4 different clinics in the Los Angeles County Department of Mental Health system. 15 of these 22 women were mothers, And most of our participants were Black or Latina, which is relevant given the well-documented racism, coercion, and judgment that many women of color have described in their experiences of reproductive health care. Our findings revealed significant gaps in the delivery of information and support around pregnancy and parenting within mental health care. I want to highlight 3 specific findings for you. For each, I'll start with a quote from one of our participants. Next slide, please. So here's the first. I've never talked about pregnancy with my mental health providers. They asked if I was pregnant, and I just told them no. This first quote illustrates something we heard a lot. Most participants had little to no experience discussing pregnancy or intentions or plans with their mental health providers. When they did recall talking about pregnancy, it was usually remembered as a quick one-time conversation, often taking place only at their initial mental health intake appointment. This is really a missed opportunity for mental health providers to better understand their patients' pregnancy goals and desires, and in turn, offer appropriate support and services. Next slide. Here's the second quote. I didn't get the answers I was looking for in terms of my psychiatric medication does harm. I needed more clarification. So this second quote illustrates a major theme we heard in our interviews. Participants were often dissatisfied with the information they received about the safety of psychiatric medication in pregnancy, and they had a lot of questions. Many received no such information. Those who did often found that these safety conversations felt vague or unsatisfactory. And what's more, discussions about medication safety rarely occurred prior to pregnancy. Some participants felt the need to conduct their own research or make medication-related decisions without their mental health provider's input, sometimes concluding that all psychiatric medications are unsafe in pregnancy and lactation, which I hope you all know, but as a psychiatrist, I can reassure you is not true. So this is incredibly concerning and unfortunately an issue that is quite widespread and not limited to this particular health system. Previous research has shown that mental health providers view reproductive topics as clinically important, but that they often lack sufficient training and guidance to address these issues in routine practice. Next slide. Now here's the last quote I'd like to share. Where can we get diapers? Where can we get formula? Where can we get kids' clothing? This third quote came up in response to us asking what the participant's mental health clinic could do to support her as a parent. Now, I really want to emphasize that most participants with children said that they really appreciated discussing parenting challenges and parenting wins with their mental health providers. But as this quote illustrates, they also express needing more parenting support and resources. So in addition to material things like this, also things like parenting classes, on-site childcare during mental health visits, referrals for resources like baby supplies. And they felt that their mental health clinic was a great place for these services to be offered. Last slide, please. So overall, our findings in this study underscore the need for greater integration of pregnancy and parenting interventions, education, support, and resources into mental health services for women living with serious mental illness. Policies that increase mental health provider and clinic capacity to address pregnancy and parenting could dramatically improve care for women living with serious mental illness and ultimately advance maternal and child outcomes. I hope that you'll take the time to read our article to hear more of the nuanced perspectives of these women who so bravely and generously shared their stories with us. Thank you for your time.
Thanks, Nicole. Up next, we'll have Amy Stiffon, Director of Native American Initiatives, Healthy Mothers, Healthy Babies, the Montana Coalition. Amy?
Hi, good afternoon. Thank you for having me. I'm so glad to be here with you all today. My name is Amy Stiffarm, and I am Aani, Chippewa Cree, and Blackfeet, all tribes of Montana, and I'm originally from the Fort Belknap Indian community in north central Montana. I work at Healthy Mothers, Healthy Babies, and we're a statewide nonprofit. We do programmatic support work for programs and organizations that are serving the perinatal and 0 to 3 population. And I the work that I'm going to show today, I did as a graduate student when I was in the Indigenous Health PhD program at the University of North Dakota. So I was able to work with HMHB as a student, and now I work there. Now that I'm done with school, I work there full time directing the Native American Initiatives program. And I am, we're based out of Helena, which is here on the map of Montana. This is the common hunting grounds, but I'm actually calling in from Missoula, which is originally home to the Salish and Kalispé people. I wanted to show this graph because I'm going to be talking about Montana. The kind of orange-ish colors, those are the different reservations in Montana. The other colors is like the original land base that people utilize. And of course, it goes up into Canada and other states, but this is just Montana. Just wanted to take a brief second to acknowledge the land that I'm a guest on calling in from. Next slide, please. So today I'm going to be talking about our LIFTS resource guide and how we engage with tribal communities, reservation communities really throughout Montana to appropriately include them within our Linking Infants and Families to Supports statewide online resource guide, or LIFTS for short. This was a big need in Montana because we're so rural that a lot of people access healthcare outside of their communities. So doctors, providers were having a hard time knowing what the resources were in local communities. So this is one way that HMHB supports our partners in organizing the LIFTS resource guide. When it came time to include the reservations as their own distinct place, not just within the counties or a city, but the actual reservation, they hired an Indigenous person. They hired me to lead these efforts and work with them on making sure, using what I was learning in the Indigenous Health program to make sure that it was done in a respectful and accurate way. Next slide, please. So just a little bit of background for perinatal mental health and American Indian, Alaska Native, women and birthing people. We don't know a lot. There's not a lot of data, but what we do know is that we have higher rates of things like postpartum depression. That's usually what is studied the most. And so we do have higher rates, but it varies like on different geographic regions and whatnot. So there's kind of some inconsistencies in the data, and that's to be expected because we don't ever want to generalize like all Native people, but knowing like specific to that geographical region is helpful. We also know that mental health conditions are the leading cause of maternal death among American Indian women and birthing people. So what's missing in the literature is really us in general. We're not often included in the literature. They often say that there's not enough of us for a true sample size. There's also not a lot of strength-based focus. It's pretty deficit-based. There's not a lot of Indigenous-led research. And what I really talk about in this paper the most is something looking at interventions that are based on traditional knowledge or those cultural values. There's also not a lot of culturally appropriate research methods. Next slide, please. So these were the three realities that influence perinatal mental health work in tribal communities today. The social determinants of Indigenous health, so acknowledging and recognizing that Indigenous people here experience different and unique social determinants of health that are related to colonization, and racism. Secondly, Eurocentric research and interventions developed for the general population are often pushed onto Indigenous populations. So it's like, you know, where that looking back at the colonial history of the United States and understanding how Indigenous knowledge systems weren't valued the same way as Western knowledge systems are. And the thirdly, that this work cannot happen. We cannot think that we have the solutions to tribal communities' problems. We have to understand that they have the solutions and that culture is a huge strength and can be utilized more for this work. Next slide, please. So Indigenous culture as strength, I just wanted to have this slide here to highlight why culture is so important. We do know that Indigenous culture, having a strong cultural identity, is a protective factor against many mental health conditions, but it's really understudied for the perinatal population. Here on the right it's from SAMHSA, and it's a list of some Indigenous cultural strengths just to give people an idea of what I mean by that. Next slide, please. Specifically to the perinatal period, there are really amazing strengths, such as looking at the perinatal period as a sacred time, birth as ceremony, extended kinship networks, things of that sort. And look to the community for their strengths, because each community is different. Next slide, please. So in our paper, when we engaged with tribal communities and really created space for cultural strengths to show, we were able to include a Native cultural connections category within our resource guide, so that the strengths of Native culture can be highlighted and, more importantly, accessed by the people utilizing the resource guide. So it relates to the two-eyed seeing approach in health promotion, where the best of the Western knowledge systems and Western medicine and Indigenous are utilized. Next slide, please. I hope you guys check out the paper and learn more about it. Guille, thank you. Here's some QR codes if you're interested in learning more about our program.
Thank you. Up next, we have Tova Walsh.
Thank you, and thanks so much. I'm just delighted to get to join everyone in this conversation. So in our paper, which I wrote together with my colleague Craig Garfield at Northwestern, our goal here was to broaden the conversation to include fathers. And while we focus specifically on fathers, I would add that I think there's a need to think broadly about non-birthing parents, inclusive of non-birthing mothers, and where they fit into our efforts to address perinatal mental health and understand how perinatal mental health impacts children and families. Next slide, please. So we do two things in our paper. First, we review the evidence on fathers and perinatal mental health. So I'm going to very briefly cover that review here. And what I want to emphasize is that we think about fathers' role in perinatal mental health as having two pieces that connect to their dual role. So first, thinking about fathers as partners. When fathers are partnered with mothers during pregnancy and in the postpartum period, father involvement and father support can be really meaningful as an influence on maternal mental health. So father support is associated with improved maternal and child health outcomes. And when mothers have mental health challenges during pregnancy and postpartum, father support can help to buffer the impact of those challenges on children. We also know that fathers can play a role by recognizing when moms are struggling and to get the care that they might need. On the other hand, fathers are also parents themselves, and they are at higher risk for mood and anxiety disorders in the perinatal period. And that is something that I think we don't know enough or talk enough about. So in our experience with our research, we'll sometimes talk to dads who say things like, I just knew I didn't feel right. I didn't think I could be depressed. I didn't know that was a thing for dads. There's awareness around the fact that, in fact, research suggests that nearly 1 in 10 fathers are at risk of depression in the perinatal period, that we know that, similar to mothers, that when fathers are struggling, that their mental health has impacts on their parenting, on relationships with their partners and children, and on child development. And then it's also important to know that they might be experienced and expressed differently by fathers. So as one example, as compared to describing symptoms of sadness, fathers might report increased irritability, or they might describe masking behaviors where they are throwing themselves into their work or increasing their substance use as an expression of the challenges that they're having. And so if you could go to the next slide, I'm just going to start talking about our recommendations. And we organized our recommendations by thinking about strategies at the local, state, and national levels. And I want to just emphasize that like maternal perinatal mental health, paternal perinatal mental health has many contributing factors and really needs of these levels and a diverse set of strategies to address. So at the local level, we made two recommendations. So one is thinking about local partnerships, and we highlight the Alameda County Fathers Corps. We also highlight the Milwaukee Fatherhood Coalition as two examples of really national exemplars that are bringing communities together and service providers in the community to very intentionally think about how can we do more to engage and support fathers in child and family services, and what might we need to do differently to support fathers and recognize unique needs and challenges that fathers have. So we recommend other counties look to those examples. We also talk about home visiting, and that's been a theme throughout the briefing today. I want to highlight the opportunity to engage the non-birthing parent in home visiting too, and think about their mental health and think holistically about the family. And so we recognize two particular models. One is called Dads Matter, and it's an intervention that has been designed as an add-on to increase and enhance father engagement in traditional home visiting programs, Nurse Family Partnership, and Parents as Teachers that are in widespread use, and to think about how to make the most of those programs to engage fathers. The second is Fathers and Babies, a unique intervention developed to specifically engage fathers and address their mental health very directly. So see both as opportunities to increase support and reduce stress for families and fathers' mental health. Next slide, please. And so we have two recommendations that we make at the state level. The first has to do with commissions on fatherhood. There are 12 states in the US that have, sometimes they're called commissions or councils or committees, different names, but state level entities that are focused on fathers. And they typically do two things. So one is focus on increasing support and developing resources and supporting exchange of resources and learning across communities and counties within the state to strengthen capacity for engaging fathers and supporting fathers. And then they also make policy recommendations. And that state level is really critical for ensuring that there is a voice at the table, thinking of fathers and ensuring that they are included in creating policies that are going to bear on children and families. One example, we have the Ohio Commission on Fatherhood here. Just as one example, they developed a really terrific screening tool to assess fathers' well-being that comes out of their work with programs around the state assessing fathers' well-being. And so they created a tool to support agencies in the state with doing that. We also recommend thinking about fathers and attending to fathers and developing state level maternal and child health priorities. So for work that's happening in states to address maternal child health, when that work is funded through the federal block grant, Title V, each state does a needs assessment and identifies priority needs. Only a few states actually engage fathers in that need assessment and thinking about what fathers might need and how fathers needs of their own and how they can be a resource for promoting maternal and child health. And so we encourage states to look to those that are doing that, like Georgia, as example. Next slide, please. Okay, and then lastly, at the national level, we have two recommendations. The first is to raise awareness and make sure that with the professional associations, including organizations representing OBGYNs, representing family medicine and others, that there is attention to being aware of how perinatal mental health challenges show up and express themselves in fathers, to screening all parents, all expectant and new parents, to changing policies and protocols to really be inclusive of all parents when we think about perinatal mental health. So we want to raise awareness there to help make referrals for needed care for those who need more care. And then our last recommended collection, and we highlight one example, Prams for Dads, developed by my colleague Craig Garfield, my co-author Craig Garfield and his team, building on the important work that Prams has done since 1987, gathering data on mothers' experiences. Prams for Dads is an effort to learn about fathers' physical and mental health and fathers' experiences and relationships surrounding the birth of a new baby. And data we needed so that we can be strategic in our efforts to promote not only fathers' mental health, but family well-being. We need better national public health data on fathers. And so Prams for Dads is a recommendation. Next slide, please. And with that, I just want to thank you and appreciate it and looking forward to the discussion. Thanks so much.
Thanks. And next we have Sandra Luce, Lara-Cinisomo.
Thank you. Well, good afternoon. Thank you for hanging in there, everyone. So appreciated. I appreciate the organization of today's panel because our study builds and adds to the work that was presented today. So I'm going to be talking about solutions from Mexican descent perinatal women and mothers of young children to address pandemic-related food, mental health, and health and safety stressors. Next slide, please. This slide acknowledges my co-authors. I want to acknowledge that 3 of the co-authors are students and students of color, so I'm so proud of them for the work that they've done. I want to also acknowledge the funders, and I have no conflicts to disclose. Next slide, please. So the research shows that Latina women in the U.S. were disproportionately affected by the COVID pandemic due to discrimination and also disparities with regard to income and access to healthcare and the anti-immigrant rhetoric of 2020. Next, also the research shows that U.S. policies were implemented to offset the economic toll of the pandemic. However, the research also shows that women of Latino descent and mothers of Mexican descent are underrepresented in the research. And so we have less information about the complex stressors that they encountered, and we know very little about recommendations they provide. Dr. Goodsmith talked about some of the resources that we need to solicit, and also other panelists today talked about leveraging their strengths, and we do that in this study. Next slide. So our objective was to identify stressors that our participants encountered, to identify actionable programs and policies to ensure their well-being in future large-scale crises. Next slide. So we focused on Mexican descent women in Southern California, specifically in San Diego. As you can see from this slide, 61% of all Latinos or Latinx in the U.S. are of Mexican descent, and nearly 90% are of Mexican descent in San Diego. Next slide. San Diego and California are important because San Diego is a border town to Baja California, my place of birth, and there is transnational migration with people moving through and the borders, but we also know that it's a very sensitive area with regard to issues of immigration and policies. Next slide. California, however, is also very important because it offers critical safety nets such as CalFresh, paid parental leave, Medicaid and Medi-Cal expansions that are accessible to many immigrant and Latino descent families. However, there are limitations, and those were still in place during the pandemic. Next slide. So we conducted a culturally and linguistically sensitive study with Spanish and English-speaking perinatal women and mothers of young children. Next slide. We implemented rigorous data collection and data analysis methods used in our qualitative study as shown here. Next slide. And what we found was that in our sample, most women were married or cohabitating. Most were foreign-born, obviously from Mexico, and a large proportion of the participants chose to be interviewed in Spanish. Next slide. We also found, however, that one of the main stressors they encountered was lack of access to food due to income loss because of lost wages, price gouging, consumer stockpiling, and shortages of food in their areas. Also, they didn't have information about food banks and where to access that food. So we solicited their recommendations, and they were so generous to tell us what we should be doing to address their needs. And that included alerting families about local food banks, food subsidies, increasing benefits such as SNAP and WIC, and they also provided recommendations for how we should provide information. I'll talk about that in the next slides. Next slide. Mental health, as we've talked about today, emerges an important issue. The participants talked about having the need to find someone to talk to, tips for coping with stress, and also resources for coping with the demands of childcare while they were experiencing depression or distress during the pandemic. Next. So the recommendations are to increase provisions for healthcare resources, to share information and resources throughout using different resources such as videos and text messaging, but also graphics to address any literacy issues. And they also suggested, as others have talked about, leveraging existing relationships, for example, with their providers to increase information and trust. Next slide. Multi-level health and safety concerns also emerged, such as lack of access to protective equipment. And we know that this is important, especially for essential workers. Latinos are overrepresented in that field. And so we need to make sure that families and workers have access to the necessary equipment. So their recommendations are to increase access to healthcare in communities and creating community clinics, providing affordable healthcare, but also to promote information across different stakeholders like healthcare providers to establish trust so that participants and communities know what is to be trusted and what information they can rely on. So the women in our study provided actionable and feasible recommendations. We hope that you will all review that manuscript, that article, because their insights are right on target, and I think that they are definitely very feasible. So our studies show that it's important to collaborate with Latinx communities to ensure that we are providing services that they need, using effective communication strategies such as videos and graphics to address any language or literacy issues, but also reinforcing personal safety through reliable and accurate information. For policymakers, the participants recommended examining barriers to services. While California provides a lot of safety nets, we know that there were issues with accessing that information due to language barriers. So policymakers are encouraged to address those issues. We found differences by language as well. For example, Spanish-speaking women were twice as many Spanish-speaking women were concerned about food access. So we need to think about barriers, and we encourage policymakers to find ways to address those, but also to empower communities by using community health workers who can come from the community and be ready to address any large-scale crises that might emerge. So I want to say gracias. Thank you for your time. I appreciate the opportunity to share our study, and we thank you for your attention.
Thank you so much. So as we move into our Q&A and discussion session, I just want to acknowledge and thank you all for providing such important work on the wisdom and lived experiences for these important groups. Just to get us started, I think Toba's presentation specifically definitely highlights some of the local and state policies that can begin to sort of address the solutions that were arising in her work on fathers and partners. But for others, how do you see local and state policy sort of supporting the things that you identified?
I'll jump in. I think that today's panel identified different ways that can be done, both engaging communities, using home visiting programs, but also informing policy. But those policies should be informed by the people who are going to be experiencing those or benefiting from them, or at least encountering them. And so, for example, Amy did such a nice job of talking about different kinds of protective factors in tribal communities, but also Dr. Goodsmith talked about conversations that should be happening across different healthcare providers. And I think that there are different ways. And Dr. Walsh also talked about the importance of local, state, and national level efforts. And I think that we should be able to talk across those levels. And I want to acknowledge Dr. Stiffarm for, am I saying that correctly, for your contributions.
Yeah, thank you. And I think that's kind of one thing that I always try to talk about is these funding opportunities and how they're written, and the deadlines and the timings, and you know, trying to make sure that it's making space for like Indigenous perspectives of health and that traditional knowledge, because it's we're catching up, you know, but there's still, you know, when we talk about evidence-based and how important that is, it's like, well, what opportunities are we getting to make sure that we can be a part of that evidence?
Yeah, I think there's so many levels that I think at the, you know, what our work is really highlights is that at the level of health systems and mental health provider training programs, really starting to integrate more of these topics and really emphasizing the importance of, you know, reproductive mental health care, having these conversations both pre, during, and post-pregnancy. This is not a niche topic. This is not a specialty topic. I can tell you when I was in training, it was treated as a specialty topic, but this is, you know, this is our entire population. Right. So I think that at a policy level, organizations can start to mandate these topics to be a part of our training, and then to ensure that that training is done in a really trauma-informed way that is also reproductive justice informed and brings in the perspectives of the people who will be receiving this care.
Great. I think we do have one question specific to Twylla's work. Do you know, or did you look into the specific stressors that contributed to poor mental health among new fathers? We'll start there.
Unmute myself. Thank you for the question. So I kind of breezed through our review of the evidence, and there are a number of factors that are associated with fathers' mental health, many of which will be familiar from work that people might know on mother's mental health. So past mental illness, family relationships in particular can be associated with father's mental health during the perinatal period. Also, role changes when fathers are struggling balancing work responsibilities and family life, changes in relationship with the partner. Those are all factors that have been associated with dad's mental health and with greater or lesser likelihood of anxiety around the time of having a baby.
Great. And for Amy, are there any other ways that local governments have or could collaborate with tribal communities in perinatal mental health care?
Oh, definitely. There are lots of ways. And here in Montana, we're doing a lot. We have a lot of great partners. So we're all kind of helping each other learn how to bringing our strengths together and figuring out how to do this. One of the awesome projects that I've been involved in is engagement days. So kind of based off of a tenet of cultural safety about learning the community that you're serving. So we've worked with the moms program and another AIM group, Alliance for Innovation on Maternal Health. And we were able to convene labor and delivery nurses, some NICU nurses from surrounding hospitals that a lot of Indigenous people travel to give birth, because there's not, usually you have to leave the community to give birth and travel. So we convened them. They did a cultural safety training first, and then they came to one of the reservations and got to meet all of the tribal programs that they commonly refer to. And that's what we're trying to tell people is like, come to the reservations, come meet people, come learn. And it was so great. The nurses were really grateful. They were like, wow. Well, the biggest takeaway was like, wow, there are so many people here that are doing everything they can for the moms and babies and birthing people in this community. So there are lots of ways to engage. Tribal colleges is another option. They're just kind of looking for a place to start, but I think going to the community for that expertise is always the right way to go.
Great. Well, it looks like we're nearing the end of our time, and I don't see any additional questions coming back, so I will pass us back to Alan Weil. Thank you all again.
Thank you again, Dr. Blibu, for leading us through the last panel, and to our panelists. We are near the end of our symposium here, but we'll have a few closing remarks before we let you all go. Once again, I do want to acknowledge the financial support we received from the PRG Fund, the California Healthcare Foundation, the W.K. Kellogg Foundation, the Hilton Foundation, Cambia Health Foundation, and ConAlma Health Foundation, all of whom supported this issue and make it possible for all of the content that you've heard today to be available at no charge. We really appreciate that support. Karen, Tabb, Dina, and Emily Dossett as our theme advisors. Again, my thanks to all of you. As we wrap up for the audience, I just remind you, of course, this event was recorded. Within a few days, it will be posted on our website. You should feel free to share links to those who missed it. We have much more content available. We will have podcasts, additional events, articles published on Forefront, all on the topic of perinatal mental health. All of this can be found on our website at www.healthcare.org. We do have an upcoming journal club on Wednesday, April 24th, focusing on the paper presented today on antidepressant prescribing increasing for privately insured people with perinatal mood and anxiety disorders. You can see the information for that on the screen. As we come to a close, just want to thank you all for your attendance of this session and encourage you to dive deeper than we were able to do in the few hours we had here by looking at the incredible material that was published in the April 2024 issue of Health Affairs. I thank all of our moderators as well for stepping in, and our presenters. With that, I will close the event, and we are adjourned. Thank you.